Hello, everyone, and welcome to this year's National Pre-Health Conference. My name is Raniela Asnar, and I'm your host director. And our 3-day conference is filled with exciting guest speakers, interactive sessions, tons of learning, and community building. And just a disclaimer, the information provided by the National Pre-Health Conference through the following webinar is for general informational purposes only. All information in the webinar is provided in good faith. However, students should seek competent advice for issues related to their specific circumstances. We make no warranty, express or implied, regarding the accuracy, reliability, or completeness of any information. So, without further ado, it is with great pleasure for me to introduce NPHC's co-founders, Alejandra and Alexia.
Thank you, Rani, and good morning, everyone. Welcome to the National Pre-Health Conference of 2021. We are so excited to have you here today, and I am truly honored to be introducing the second yearly conference of our organization. My name is Alejandra Baena, and I am a rising senior at the University of Pennsylvania and the co-founder of MPHC. At MPHC, our mission is to inspire self-confidence into the next generation of healthcare professionals. And we envision a world in which America's healthcare system is made up of professionals from all backgrounds. NPHC is a network created by students for students, and our team understands the challenges of navigating the pre-health path. This is why we have put together this event that will inspire you on your journey towards becoming a healthcare professional. Our event strives to expose you to different career paths in healthcare, teach you how to become a competitive candidate for professional and graduate schools, and expose you to expert advice that will help you reach your professional and personal goals. And most importantly, we want to welcome you into our community of students and healthcare experts. Our MPHC community is a friendly, non-judgmental space where pre-health individuals from all walks in life can be free to be themselves. So we encourage you to take advantage of our event by engaging with our sessions, asking any questions you may have, and reaching out to our leadership team if there is anything we can do to help improve your MPHC experience. We also highly encourage you to stay connected with MPHC after the event through our year-long initiatives such as a Discord, newsletters, and our social media accounts. Lastly, I would like to talk about this year's conference theme of Unity in Healthcare. Why is Unity in Healthcare so important? The COVID-19 pandemic challenged many aspects of the delivery of medical care across our nation and the world. But it also highlighted the importance of interprofessional collaboration among healthcare workers in order to solve complex medical cases. By intertwining the experiences of different healthcare providers, healthcare teams work more efficiently and patients have more effective treatments and higher overall satisfaction. As future healthcare professionals, we would like for all of us to learn together about the importance of interprofessionalism and collaboration in the medical and healthcare fields. And this is why our conference focuses on healthcare professions and emphasizes the way these professions complement each other. And now I would like to introduce MPHC's co-president and my lifelong friend, Alexia Childers. Please join me in welcoming Alexia.
Thank you so much, Alejandra. And you have been a lifelong friend to me the past several years, ever since I've known you. And it's been such a pleasure leading the National Pre-Health Conference alongside you. Welcome, everybody, to the National Pre-Health Conference of 2021. This past year has been very busy as our team implemented your feedback from last year's conference and ensured that our program contains more diverse healthcare career topics, interactive sessions to promote student engagement, and opportunities to network with national organizations, programs, and other pre-health students. Furthermore, we have also worked on gathering resources through our newsletter and Discord so that you can stay connected with an MPHC community all year round. To our advisory board, thank you for believing in our mission and investing your time in our conference. To our sponsors who will share their resources during the tabling sessions, thank you for promoting our event and help us reach students all over the country. And to our wonderful guest speakers, thank you for volunteering your time and effort to share your knowledge and medical expertise to the next generation of healthcare professionals. Here's a glimpse of what we have in store for you today. First up, we have the Path to a Nursing Profession with Melanie Martin and Jessica Burnett. Then Psychiatry is a Career by Dr. John Crystal. Exploring Competitive Medical Specialties as an Underrepresented Student with Dr. Shavana Nguyen. A Career in Public Health with Leslie Petroff. Making a Career in Medicine Work for You with Dr. Jennifer Lincoln. Innovative and Collaborative Approaches in Physical and Occupational Therapy with Shelley Prosko and Betsy Shandalov. An Overview of Dentistry and Healthcare with Dr. Sheridan and Dr. Crawford. And to end the day, a feature in dermatology with Dr. Christina Collins. We also have tabling sessions, as I mentioned, from 1:30 to 2 o'clock Eastern Time today with the American Medical Women's Association, the American Medical Student Association, Alpha Epsilon Delta, and Simply Neuroscience. We would like to thank you for joining us today for MPHC 2021 and look forward to meeting as many of you as we can throughout the conference. We hope that the next 3 days inspire you in your journey towards becoming a healthcare professional and allow you to meet students and speakers who are as passionate about medicine as you are. Thank you.
And now we want to go over some conference logistics regarding the Zoom platform. As a reminder, there are several features that we would like for you to use in order to stay engaged and interact with both panelists and other students. If you have any questions at any point, please use the Q&A chat feature. We also will have polling questions at the end of each session in order for us to get feedback about what you like and didn't like about our sessions. So we will be launching polls after every session. We also have a raise hand feature that will allow you to raise your hand so that a host can call on you and allow you to speak. And in addition to that, we encourage you to use the chat at any point if you have any questions, and also to stay engaged with the content and give your feedback in real time.
We would like to thank all of our sponsors today, especially those who are joining our tabling sessions, for helping promote our conference. And if you would like to check out our sponsors online, visit our website at www.nationalprehealthconf.org.
So we would love to hear your feedback about our conference, and we have created two main surveys that or three main surveys that we will be sending out. A lot of you guys have already filled out the pre-conference survey, which will allow us to learn about what you have learned throughout your conference, throughout the conference, and your confidence in different sections related to the material we covered. And you will receive a post-conference survey that will help us learn about what you learned throughout the conference. And this survey is not, you can take it if you want. And the other feedback is, the other survey is a feedback survey, which we would like for all of you guys to take to hear any feedback that you have about our conference. And this one will be mandatory for any students that would like to receive certificate of participation.
I would also like to announce that we have a t-shirt this year. If you go to www.nationalprehealthconf.org/mphc-2021/merch, check out our t-shirt that we made this year. I'd also like to mention, if you filled out the pre-conference survey, and then you should receive an email from me from the post-conference survey, you are eligible to be entered to win a free t-shirt. However, this won't be available for the next month or so I definitely recommend checking out our t-shirt online at Custom Ink.
As I mentioned, we would love to stay connected with you throughout the year. So we encourage you to follow our social media accounts. And here you can find all the names that we have for our Instagram account, Twitter, Facebook, LinkedIn, and now we also have a Discord where we want to create this virtual community of students so that we can stay connected with you throughout the year.
We also have a special event on day 2, which is tomorrow from 2 o'clock to 3 o'clock Eastern Time. Here we will have a select number of students give digital presentations of their remarkable research projects. And at the end of day 3, we'll be giving out 3 awards, which include Best Presentation, Audience's Favorite, and Most Innovative.
We also encourage you to check out our program guide, which you can find on our website. Our digital design team worked very hard to put this together, and this could help you throughout the conference to learn about what sessions we'll be covering each day, the background from our speakers, more information about our leadership team, and everything you need to know about NPHC you will find in our conference guide. So please check it out at www.nationalprehealthconf.org, and you go to the NPHC 2020 tab. 2021, sorry.
All right, now for a more interactive portion of our opening statement. For those of you who are familiar with Pear Deck, for those of you who are not, I will go ahead and explain the instructions on how to join our presentation. So just give me 1 second. Sorry for the delay. Good. All right, I'll share my screen again. So go ahead and get out a phone or another tab in your computer and enter in the browser joinpd.com. And once you go there, enter this code. All right, awesome. I'll give it about 30 more seconds so we can get started. All right, and if you haven't joined yet, you can still enter the code at the top right corner here. All right, so for our first question, go ahead and click one of the colors on your phone and place a dot of where you're from. You can say where you're from, where your family is, or where you are currently. So I'm in Arizona. For those of you in Arizona, I'm going to click over in Arizona. I'll go ahead and show responses. All right. That's awesome. Welcome, everybody. So a lot of our team members are from all over the country. I'm from Arizona currently, but I live in Florida. That's where Alejandro and I met. Alejandro's in Pennsylvania right now. We have some friends in California, and all over the country in Minnesota. And yeah, so thank you for joining. Okay, let's go to the next question. Where are you in your education? So, wow, quite a lot of undergrads. Okay, awesome. Welcome, everybody. All right, we'll go ahead and go to the next question. What are your interests? Why are you here today? Which sessions would you want to join based on your interests? All right, we have quite a few pre-meds. Okay, awesome. And then lastly, which sessions are you looking forward to most on day one? So these are all the sessions listed for the day today. Go ahead and put a number in the chat box. You can put multiple numbers for which sessions you plan to attend or which sessions you most look forward to. So I'll just give you a minute to take a look at the list, and then I'll open the responses. All right, let's take a look at what you responded. Okay. All right, so we have some of our sessions for pre-meds. So making a career in medicine work for you, a future in dermatology, psychiatry is a career. Awesome, everybody. All right. Thank you so much for joining and playing with us for this Pear Deck. I will go ahead and resume our presentation. All right, so next up, we have our first session of the day. And we will go ahead and pause for 5 minutes to let our guest speaker and the session host get prepared. So go ahead and hold tight. And thank you so much for waiting. And we look forward to seeing you throughout day one.
Good morning, everyone. My name is Ruhi Sahu, and I'm a student at The Ohio State University. Today, I'm excited to be hosting the first session of our conference, The Path to a Nursing Profession, featuring two amazing speakers who will be sharing their insights on pursuing a career in nursing and navigating this career path. Jessica Barnett is a nursing student at Penn's Accelerated BSN program, with plans to work for a year before pursuing her master's as a pediatric acute nurse practitioner. Melanie Martin is also in Penn's Accelerated BSN program, with an ultimate goal of working outpatient as a neurology nurse practitioner. Attendees, feel free to put your questions in the Q&A section throughout the presentation, and we'll get to them soon after. Please help me in welcoming Jessica and Melanie.
Hi, everybody. Let me just share my screen. Whoops. And we will be using Paired Deck, which I think you are familiar with. So feel free to join in to make it more interactive in answering the questions. Let's see if it loads. All right, so you can join here. I'll give you a couple minutes to join. Okay, good. I see people joining. Slowly moving up. So yeah, just to start, as you guys are joining. So yeah, so Jess and I are in the Accelerated BSN program at Penn. We graduate in December, and we're going to give a little bit of background about our path to nursing, as well as just, what makes nursing unique as a career, and also all the different career options that you have if you are thinking about pursuing a career in nursing. All right, I think I'm going to go ahead and get started. It looks like it's slowing down a little bit, so let's get started. All right. So I'm going to have Jess introduce herself first.
Hi, everyone. I'm Jess. I am from Vermont, and my background is when I first started college, I knew that I wanted to be in the health field of some sort. I wasn't really sure what that would look like. And so I started at St. Michael's College, and I got a degree in biology. I was thinking maybe that I would go to PA school to become a physician's assistant, but again, wasn't really sure. So I got a degree in biology and minored in Spanish and chemistry. And really what enabled me to find my direction in the healthcare field was some of the experiences that I looked at throughout my college career. So some of the noteworthy ones, in my first 2 years of college, I volunteered for Child Life at a local hospital. If you're unfamiliar with Child Life, they provide a lot of assistance to pediatric patients. So it's like providing games or developmentally appropriate education tools, and it's kind of helping pediatric patients feel more comfortable in the hospital setting. And then I also participated in immunogenetics research. So that's research at the bench, doing a lot of like pipetting, looking at DNA sequences. And from there, I started narrowing things down, like, yeah, I don't think I want to go into research. And sort of my most defining experiences were the last two listed. I studied abroad through a pre-health program through Middlebury College. And this program allowed me to be enrolled as a nursing student in a university in Viña del Mar, Chile. And so I got to enroll as a second year nursing student. And so I had clinicals in Chile and took some classes there and found that, like the nursing model is something that I was really interested in. From there, that was the beginning of my senior year of college. And the second semester of my senior year in college, I had an internship with the Vermont Medical Examiner. So this is the person who does autopsies. Sounds kind of gory, sounds kind of weird, freaky, but it was honestly an incredible learning experience, both in just anatomy of the human body, but also more so in like the perspective of what healthcare can do for people. Also where I wanted to fit in with healthcare and sort of the life perspective on, what's important and where do I want my career to go. I had a lot of exposure to physicians in this role and found that, I don't really identify with going with the disease model, didn't really want to go down the doctor route. So then after college, I wanted a little bit of a break. So from 2018 to 2019, I was an English as a second language teacher in South Korea. So I taught elementary students English. There I solidified, I want to work with kids. And in that time, I realized I really need to be in healthcare. I know that I like the nursing model. I know I like working with kids. So I returned from Korea and started applying to nursing programs. And in the time that I was applying to nursing programs, 2019 to 2020, I worked as a medical assistant at a community health center. And for me, working as a medical assistant served as a way to get my foot in the door in the medical field and get exposure to taking down patient medical histories, communicating with providers and learning sort of the dynamics within healthcare, and then working on the hard skills of like administering a vaccine or drawing blood and things like that. So those are some of the highlights of my experiences. If you have any questions about those later, as Melanie said, and people out there said, put it in the chat box and we can address it later. But that was my path to nursing.
All right, so, and then just a little bit about me. So I graduated from Arcadia University, small liberal arts college outside of Philadelphia. I got my BA in biology in 2015. I also minored in psychology. And that was sort of my way of trying to create my own neuroscience major because we did not have one at my school. But I always was interested in science since I was little. I was always interested in the brain specifically. And so I kind of thought I wanted to go more of the bench science route. And so I conducted a lot of research at my college, which was nice because it was such a small school. I was able to work really hands-on with my professors for all 4 years that I was there. I interned at Thomas Jefferson University in Philadelphia between my junior and senior year. And that sort of solidified, okay, I'm going to pursue the research route. And so I ended up actually pursuing a PhD in neuroscience after graduation. I went right into the program. I quickly realized that that was not for me. I just really felt so disconnected from working with people. And I liked my coursework a lot. I liked what I was learning. I liked my professors, but I just didn't feel like I could do the bench work on a day-to-day basis. I wanted to be more with people, working, on directly with disease research and less with working with rats and mice every single day. So I ended up graduating with my master's in neuroscience from Drexel in 2017. And after that, I sort of knew I wanted to pursue a more clinical route. I just wasn't quite sure yet what that was going to look like for me. So I spent some time teaching neuroscience to middle school and high schoolers after graduating that summer at Franklin and Marshall University out in Lancaster. And that was a very interesting experience, just kind of very humbling to teach. I have a lot of respect for teachers. It wasn't easy, but that sort of helped me build on my knowledge base a little bit. And then I ended up applying to jobs at the University of Pennsylvania. I really wanted to work at Penn. I knew that that would be the best place to do clinical research. And so I must have applied to over 100 jobs, just hoping to hear back from one of them. And I had my supervisor reach out to me and ask if I wanted to interview for a completely different position than what I applied for, which is just kind of funny how life works sometimes. And I ended up working at the Penn FTD Center for almost 3 years. I did neuroimaging, so I conducted a functional MRI study. I pretty much would work with patients from our neurology clinic and guide them throughout a research day. I collected all of the data, I scheduled all of the visits, I analyzed all the data. And through that experience, I realized, well, wait a second, I'm not just doing research, I'm also interacting with people on a daily basis. I really, really enjoyed working with not only our patients from our neurology clinic, but also the caregivers, because these people were dedicating their time, really long research days, coming in, getting MRIs, cognitive testing, blood draws, lumbar punctures, and they weren't really getting much out of it. They were just donating their time for research studies. And I thought, okay, I really want to help these people more than what I'm doing now. And so at that point, I was inspired by a nurse practitioner who worked in our lab. And I thought, I've never considered this career path before, but this would allow me to do clinical research, work directly with patients. And so I felt like that was the best fit for me. And so I applied to nursing school, and here I am at Penn now. And I'm very happy with this career choice. I feel like it's a much more rewarding career path than where I started. So similar to what Jess said, if you have any questions about my very circuitous path to nursing school, feel free to put it in the chat. And all right, so now we kind of want to hear from you and see what career path you guys are considering now at this stage in your education and career. So I believe you should be able to see options. If you can't, let me know. This is my first time using Pear Deck, so I'm hoping it goes okay. I see. Okay, I see responses coming in. That's good. Let's see. I'll give you a couple minutes. Obviously, I couldn't list every single career path in healthcare on here, but I know there's some missing, like public health. I'm not even sure if I have research listed on here, but as far as, healthcare fields, I tried to list a couple different options to give you. Let's see if I can show responses. Oh, there we go. Oh, lots of med school. Wow. Okay. Doesn't really give me the number breakdown, does it? Oh, no, it does. Okay, 38 people for medical school. All right. See if any more are coming in, but looks overwhelmingly medical school. Hopefully you can learn something from this presentation too. All right, so that gives us some information about you all. And so as far as why nursing, in comparing sort of the different career models, and since many of you are interested in pursuing medical school, we thought we would just kind of compare and contrast some of the different career paths. So in my consideration of the healthcare field, I knew I did not want to pursue medical school. Both my older siblings actually are doctors, and nothing against doctors. I just kind of knew it wasn't the right path for me. It never really felt like the right path. It wasn't really something I had considered, but I definitely was debating between PA and NP and kind of looking at the different training models. And so you can see that physician assistant is more of a medical based training model, whereas a nurse practitioner obviously is under more of a nursing model. The years of education are definitely different. So after you graduate from college, you would go for 2 to 3 years for PA school. Nursing school, obviously as a second degree, we had to complete some prerequisite courses before we began our program. And then, but typically it would be 4 years and then an extra 2 years, depending on your NP specialty. That can kind of vary a little bit. And then again, unlike a physician, there's no residency required, but you do specialize. So you can specialize in pediatrics, you can specialize in geriatrics, which personally I like because it sort of hones in on your interest, but you're never really locked in the same way you're kind of locked into a residency. If you're pursuing, I want to be a neurologist or I want to be a cardiologist, there's a little bit more flexibility in nursing. And you can practice independently as a nurse practitioner in some states. Other states, you're still overseen by a physician. Those laws are starting to change about how much independence you have as an NP. But it kind of depends on the state that you live in. And so if that's something that you're considering, I would recommend looking into your state requirements right now and kind of, getting a sense of, okay, what does my career path look like after I graduate from nurse practitioner school or from PA school? PA is supervised under a physician. And then the salary ranges are very different. So I think this infographic is a good ballpark, but I would say it definitely depends on what you're specializing in. I mean, I know that if you're a nurse practitioner and you're specializing in anesthesiology, that's gonna, your salary end is gonna get bumped up a little bit more. Likewise, there's a vast variety in physician salary ranges depending on what residency you pursue. And so just keep this in mind that this is an estimate, but this isn't necessarily an exact science. All right, I'll let Jess take over.
Yeah, so next we'll have you name some nursing degrees that you can obtain. So whether someone who has the degree or you've heard of it, you'd like to check if what you've heard is correct, just type in some nursing degrees that you know of.
Oh, I can scroll. Good. Nice.
Awesome. Yeah. You guys know a lot more than I think I did before I started. So this is great.
Cool. Great.
Awesome. So I think we can kind of go to the next slide and I'll break down some of the, within the nursing realm, what you can obtain. So we'll start off with the CNA, which is a certified nursing assistant. This is a role that if you have a high school degree, you're able to then take a certification program in order to become a certified nursing assistant. So it's a diploma nursing program. It usually takes 4 to 12 weeks. And the CNA role, you are typically helping with a lot of activities of daily living. So that's helping people bathe, eat, get dressed, walk around. CNAs can work in the hospital setting and they can also work in outpatient settings, typically in long-term care facilities or nursing homes. And so a CNA will always be under the direction of a registered nurse or an LPN, which is the licensed practical nurse. And so we'll go kind of to the next step, the licensed practical nurse. That again is a state approved certification. You obtain an associate's degree in nursing and that can take 12 to 18 months. And in an LPN role, you gain a little bit more autonomy in what you're able to do. However, one of the limitations is that you are not able to assess patients. So an LPN can help with all those activities of daily living. They can, state by state, it varies, but LPNs are often able to administer certain medications. So if they are at a long-term care facility, they might be the one passing the morning meds, but an LPN always remains under the direction of a registered nurse or a provider like a doctor, a PA, or a nurse practitioner. And they would have to sort of alert a registered nurse about some concerns, but they're not able to provide an assessment or recommendations to a provider in the way that a registered nurse is. And so registered nurse, so Melanie and I, when we graduate with our bachelor's of science in nursing, we'll take the NCLEX. And after we pass the NCLEX, we will become a registered nurse. And so registered nurse is what you see most often, who is in the hospital setting. You can also be in long-term care, outpatient, and we'll get into some of the other specialties. But A registered nurse is able to administer medications. They are the ones assessing a patient, taking vitals, and they are also in charge of delegating tasks to the LPNs and CNAs. And so in the registered nurse role, there's a lot of different area settings and specialties that you can work in. Sort of one of the transitions that's happened or that's been happening is that to be a registered nurse, they used to have associate degree programs in nursing. They also used to have like hospital training programs, and that's sort of being phased out. Those were 2-year degrees, and now it's most people who have an associate's degree are being encouraged to get a bachelor's. Otherwise, people are just getting bachelor's degrees in nursing, and the difference is 4 years of training to get the bachelor's. And if you are getting an associate's degree in nursing, sometimes that is more technically focused, whereas the bachelor's of science, you're taking a lot of courses, like some of the courses that we take at Penn, including like public health and like certain case study courses or other things that sort of hone in on the holistic approach of nursing, and some of the psychosocial concerns and social determinants of health, and things that may not be allowed for in a 2-year program. Then a step up from the registered nurse is going to get your master's. And so after you are a registered nurse, you can go back to school to get your master's in nursing. And again, this is something that you can specialize in. So when you become an advanced practice registered nurse, you can specialize in something called like a certified nurse midwife, where you're helping deliver babies, things like that. You can become a nurse practitioner. Nurse practitioners can work as a provider in hospitals. They can work in outpatient settings. So you may have like your main medical doctor that you go see every year for your annual physical might be a nurse practitioner. A nurse practitioner can also be in like critical care or in an ICU in a hospital. So there's a lot of specific training that you have to go to specialize in primary care or critical care at that advanced level. The biggest difference between a registered nurse and the advanced practice nurse is an advanced practice nurse is able to diagnose and prescribe medications. And as Melanie mentioned, in some states, the advanced practice nurse is able to practice independently. So they can open their own practice. Again, that's state by state. But whereas a registered nurse is sort of assessing and administering medications, the advanced practice nurse is making those final decisions, diagnosing, and delivering, like asking the registered nurse to carry out those actions. Another transition that's similar to what happened with the registered nurse, now with the advanced practice nursing degree, you can also get a doctorate. And so there are some specialties that are already shifting towards getting a doctorate of nursing practice, whereas for other specialties, just a master's of science in nursing is sufficient. For the master's of science, that's a 2-year postgraduate. Doctor of nursing, it's also 2 years, but sometimes with the research that you might be doing in your doctorate degree, it can be a little bit longer than 2 years. And so the doctorate of nursing practice, a lot of times, yeah, it's more, it can be a little bit more research focused. And at this point, you do not need a doctorate in order to be a nurse practitioner or like a nurse midwife or anything like that. But that shift is in conversation of, should it be a doctorate level degree? So that's something to stay in tune with if you are pursuing a degree in nursing, is sort of what you want that final degree to look like for yourself. If you want it to be a doctorate, or if you're not as interested in research, then maybe just the master's of nursing is the best route.
All right, so a little bit about the curriculum, and Jess sort of alluded to this a little bit before, but there are some, basic science classes that you would be required to take as part of the BSN curriculum. So this again is going to look a little bit different if nursing is your first degree or if it's your second degree. But you're definitely going to have basic sciences like biology, chemistry. As far as some of our prerequisite courses, we were required to take human anatomy and physiology, microbiology, nutrition. There's also some other courses like statistics that you would be required to take either within the program or before starting a second degree program, as well as courses in social sciences, psychology, ethics. Ethics is a big one too that's required within our curriculum, just kind of learning the history of bioethics and things that sort of were done incorrectly in the past so that we can learn from them and be better providers in the future. Same thing with public health courses as well. That's really important to the nursing field as a whole. And then in junior and senior year, you start to kind of transition to more clinical based learning. So that's really when you start to get more of that hands-on experience. And so you have clinical rotations, similar to, I guess, similar to medical school as well, where you kind of rotate through different areas of practice. These would include things like psychiatric nursing, pediatric nursing, medical and surgical units, and then nurse leadership. I feel like we're forgetting one in there. Oh, women's health, OBGYN as well. So those were some of the clinicals that Jess and I have already completed. And this is really the time in which I would say you learn what you enjoy most. If you are unaware yet of what career path or what specialty you're most interested in, clinical rotations are the best time to really figure that out and see what you enjoy most about nursing. And so for me, actually, I would say my community clinical has been my favorite so far because I got to work with geriatric patients directly. We actually were able to administer COVID vaccines to people in the community. And as somebody who wants to specialize in geriatrics, I really had enjoyed working with the older population. But for some people, when they do like their pediatric rotation, it sort of clicks like, yes, this is exactly what I want to do. And that's sort of, kind of the point of clinicals is to learn more about what you're interested in. And of course, programs are different depending on what university you go to. Some start nursing courses in the first 2 years and others might wait until your junior year. So it really just depends on the program. If you are applying to nursing school, I would be sure that you kind of look into the courses that are required, any kind of prerequisite courses that you would need, and just make sure that all those requirements are met when you're in that application phase. Okay, and so now we just want to give you an opportunity to see how many different nursing specialties that you can name. I said 30 seconds. I'll give you maybe less, maybe more, depending on how the responses come in. But there are, an incredible amount of nursing specialties that I wasn't even aware of before starting nursing school. So I'm curious to see how many you all can name. So let's see if I can show the responses as they come in. Nice. Oh, good.
Yeah, these are great.
I can see typing.
Yes.
I can see them like real time as they're coming in. I'm like, wow. All right, good. Let's see if yep, there's neurology. I see a geriatrics slowly coming in.
Yep.
All right, nice.
You guys hit on a lot of the nursing specialties, which is great. Some of the ones that I know a lot of people wrote down. So you have pediatrics, geriatrics. So pediatrics working with children up to ages 18, geriatrics, kind of anything above that. Critical care is interesting. In critical care nursing, you can be in a lot of different settings. Ultimately, if you're a critical care nurse, you're working with patients who are very ill, but that can be a patient that's very ill before surgery, after surgery, in an intensive care unit, in an outpatient setting. So critical care is kind of an umbrella term, and you still might work in different departments of a hospital. So I just want to clarify that. Primary care, so like I said, like if you're when you go to your annual physical, and these are all as a registered nurse after you go get your bachelor's, or if you have your associates in nursing, and after you take the NCLEX, these are all areas of nursing that you can work in. So as a registered nurse, that national board exam, after you take it, You can really apply to any nursing position that you want. Certain nursing positions will require you to get an additional like small certification, whether that's like basic life support or some of the other ones that I'll mention later require an additional course. The hospital may pay for it. Or it's when you like get your NCLEX, you're a licensed nurse, you can apply to work in the pediatric ICU, and they will train you on the job, and then you can call yourself a pediatric ICU nurse, but it's not that you graduated from your nursing program and that's the only thing that you can work in. You can kind of shift between all of these. So I think that's, as Melanie talked about, that's one of the amazing things about nursing is that in your clinical rotations, you can sort of hone down what you think you're interested in. And then once you get in the working atmosphere, you can also learn, like you can have a job for a year and decide, I thought I wanted to work in pediatrics, but I'd actually really like to work with adults. And you can make that shift as well. So that's something that's sort of liberating if you're someone who's like, oh, I know I want to be in healthcare. I know I want to work with patients, but I don't want to have to decide and go down a route of 4 years of residency and then kind of be unhappy with what happens. So another specialty that's really interesting is the clinical nurse leader. And so this is a person who is most often on a hospital floor. They're the ones who provide the most up-to-date education for the nursing staff. So they'll spend time, they'll go to conferences, they will be looking up current research on best practices, and they will help educate the nursing staff to make practices safer for patients and for nurses. And they're great. If you are someone who's kind of interested in education, this is a great blend of nursing and education. Some of the ones that I didn't know about were burn care and flight nursing. So burn care, you are a registered nurse, and then oftentimes you will get like an additional certification in burn care support. And so you are someone who you may be working in a burn care unit in a hospital or in an ICU, and you're specialized to treat people who have suffered from burns resulting from a natural disaster, from any sort of violence, or like if their home caught on fire or anything like that, you are the one providing care. And it's very specialized. So in that sense, there aren't a ton of burn care nurses, but it's a really unique field that you can look into. Another one is flight nursing. So this is sort of like being a paramedic in the air. So you're working on an airplane, on a helicopter, and you are, say someone gets in a car accident and they need to be flown to a nearby hospital, you're actually the nurse working on the helicopter that's transporting that patient. So you're able to provide emergency level care, but you're doing it in the environment of a helicopter, so you have limited resources. You may or may not have a physician with you, and you have to be in communication with not only the emergency responders at the site, but then also the hospital. So in that sense, it can be an intense but often very rewarding career path too. That's something that you're interested in. Oncology, that's working with patients with cancer. You could work with pediatric oncology or adult oncology, cardiac, anything. There are cardiac ICUs, so that's specifically looking at the patient's heart. And so you can kind of you can be in a cardiac ICU, you can be cardiac outpatient nurse. NICU is neonatal intensive care unit. So that's working with infants, and most often they're born prematurely. So I think at Pennsylvania Hospital in my clinical, the one patient was born at 21 weeks. That was like the earliest a patient had been born at. And so you would be the nurse monitoring that patient all day. You'd be bathing the infant, but also like ensuring that they are growing properly, any of their medications that they need. You are kind of in charge of that baby, obviously under the guise of a physician or nurse practitioner, but very interesting. Med-surg, this is like medical and surgical care. A lot of people will go for a med-surg position as their first job out of nursing school to gain the most exposure and most experience, because you're dealing with patients from across the board with many different ailments. So med-surg is sort of an all-encompassing umbrella term as well. ICU, intensive care unit. Diabetes, this is a field that's definitely growing a lot, given the United States population, what we're dealing with diabetes. And so you can, this is also a great role for someone who's interested in sort of education and healthcare, because diabetes requires a lot of patient education. And so you can really be involved in the patient's life and making sure that they're receiving all the services they need and giving them education that's relevant and most appropriate for them. Forensic nursing is one that's focused on nursing in or helping provide like trauma-informed care. And so when you're a forensic nurse, you're often engaging with patients who suffered from violence, abuse, neglect. And so this is sort of a blend of psychiatric nursing in the sense of you are thinking about how the patient's emotional stability is while also helping them recover from any physical injuries that they have suffered from. Infectious disease can kind of fall under that public health role. So this is something where you could be in a hospital setting, but you could also be outside of a hospital setting, sort of in legislation or a political environment as well. So those are just some of the nursing specialties. There are definitely more out there, but hopefully this gives you an idea of just all that you can do as a registered nurse.
That was great. I learned a lot too. Yeah, there's so many options in nursing, which I think is what makes it such a great field. Okay, so another opportunity to participate. This time I want you guys to guess a number of how many different nursing careers you think that there are. Obviously it's hard to approximate, but I just want to get a sense of how many you think. And maybe now you have a better idea after Jess kind of explained some of the specialties that obviously there's a lot more than meets the eye. Let's see. Oh, nice. Oh, I like this display. Okay, it looks like the mean is roughly 32. Let's see. Oh, it's jumping. Let's see how many responses. Okay, we only have, all right, 30 responses so far. 40. All right, so there are definitely, I would say, well over 50, probably maybe even 100. I couldn't even find a number online, but there are so many different career options in nursing. And so I won't go too much into this, and this is kind of hard to read, but this is just to give you an idea of like the sheer volume of career options. Anything from being a bedside nurse to working in primary care, travel nursing, again, as was mentioned earlier. This is sort of becoming a more popular field, I would say, just because of the flexibility of like, you can kind of just, you can see the world and also practice nursing at the same time, which as someone who loves to travel, I think sounds like one of the coolest jobs ever. And then again, going into public health, I think the thing with nursing too, is that there's an opportunity to overlap with other careers. So you can collaborate with a lot of different people. So if you're working in clinical research, you're going to be working with people who have their PhD. If you're working in public health, people who have their MPH, forensic nursing, working with scientists. You can do bioinformatic nursing. We actually had somebody speak once in one of our courses, I can't recall which course it was now, who basically was involved in the development of electronic medical records. So she was involved in sort of how can we best design an electronic medical record to suit the people who are using it, to help the nurses, to help the doctors, to help everybody in the hospital, save time in charting all of that information when you see a patient, laying out the design in a way that makes the most sense so that you can easily see their medications, you can see their physician orders, what else? Seeing their visits, seeing all the notes that people enter into the electronic medical record. And a lot of that design was coming from nurses, because nurses are the ones who are actually using that software on a day-to-day basis. And so not just being at the bedside, but also as a nurse being more behind the scenes in the technology aspect of things. And then of course you can be involved even higher up than that, doing more of administrative work. And so I believe it's the CEO of HUP, correct me if I'm wrong, is a nurse. She came from a nursing background herself. And so that's also kind of neat to have the person who is in charge of the whole hospital basically be a nurse and kind of view things from a nursing perspective, a nursing model. And then there's also legal nursing, which is exactly what it sounds like, you know, practicing nursing expertise in the realm of the law and legal requirements. And so again, that kind of goes back to that collaboration, that there's so much overlap in nursing. You could be working with lawyers, doctors, you know, scientists, and you're not really ever bound to just nursing. There's so much more than just nursing. And if you choose to practice as a bedside nurse and you decide, okay, I've enjoyed this part of my career, now I want to move on to something else, you always have that flexibility to do that. You're never trapped into one career. You're never locked in. And so that's the beauty of nursing as a career. And so, yeah, Jess, you want to take this one?
Sure. And this one I'll keep kind of short and sweet so we have time for a Q&A. But basically, as Melanie said, like there's so many different people that you in professions that you can interact with as a nurse. And so we just wanted to highlight, especially with unity in healthcare being the theme, thinking about when you are a nurse, and even if you are pursuing like MD roles or OT, PT, we're all going to be working together. And that's really important to remember, that we are here for the patient. And so whether you are, whatever healthcare role you're in, knowing that you have people to ask for referrals for or provide more specialized care. So if I'm a nurse, I'm noticing my patient is having difficulty walking, I'm going to encourage them to get up out of bed, make sure they have their socks and shoes on, and make sure they're in a safe place. But I'm actually going to refer physical therapy to come in and work with that patient, because I don't know the specifics of maybe why that patient is having trouble walking, and physical therapy has the training to help them do that. And this can happen through like dietitians getting involved, helping create more accurate nutrition plans to help patients heal faster. You can have social work who are aware of community resources. So after a patient's discharged, social work can follow up with them, make sure they're able to pay their bills or meet some of those outside resources that they really need. Pastoral care can help with the patient while they're inpatient and sort of dealing with some of their emotional and spiritual needs. Palliative care is amazing with helping with pain. And palliative care, just so everyone knows, is not the same as hospice. Palliative care can help anyone at any stage of their illness or injury. It doesn't mean that they're like close to death or anything. It's just helping with pain. Occupational therapy, speech pathology, all wonderful resources that we need to be aware of so that we can best serve our patients. And just as a reminder, nurses dispense comfort, compassion, and caring without even a prescription. So this is, I think Melanie and I would both attest to, like, this is a huge reason why we pursued nursing, for that holistic approach and really caring for the whole person. Melanie, if you want to add anything to that quote.
No, I think that's great. I think you summarized it perfectly. So thank you all for your attention. And I guess now we can try to open it up for some questions.
Yeah, we can go ahead and move on to our Q&A. Would it be possible if you could stop sharing your screen?
Yep.
Great. Perfect. So our first question is, how long is the accelerated program that you're in?
So currently our program is 18 months. And we kind of started shortly after COVID. So our program was sort of partly virtual. Our clinicals were in person. But yeah, it's an 18-month program and we graduate in December.
Okay, our next question is, before deciding on nursing, what are some specific career paths you considered as a biology major?
Well, I guess speaking for myself, I considered mostly bench science. I kind of thought, okay, I like science. It seemed like the next logical step was to work at a bench, especially because I knew I didn't want to go into medicine. I didn't want to become a doctor. So I never really ever thought about any kind of other career path besides like bench research until I got to clinical research. And then I was like, wait a second. And then the light bulb sort of clicked for me. But yeah.
I was way all over the place. I started as biology major thinking I wanted to go physician assistant. I realized I may or may not have the patient contact hours that I would need after I graduated. So that's something like PA school, you have to have a certain amount of hours. It's definitely possible to get. You can work as an EMT, a CNA, you can definitely get those hours. Just the trajectory I was taking, I didn't know if I would be able to. So PA first. Then during the study abroad, I liked nursing, but I also had a very difficult time during study abroad. Everything was in Spanish, so half of it I didn't understand. So I was like, do I like nursing, or is it that it was difficult because it was in Spanish? Like what? So I kind of was like, maybe I like nursing, but I don't know. And then when I did the internship with the medical examiner, I thought, oh, maybe I'll become a doctor. Like I hadn't really considered that, but I was working with doctors and like, oh, this is something I could do. So for me, I kind of jumped around through all those different career paths. And it was really the culmination of experiences that I got. And then a lot of it was shadowing. So I didn't mention this, but I shadowed as much as I could. So I shadowed registered nurses, I shadowed nurse practitioners, I shadowed doctors, I shadowed PAs throughout the time I was in school. So I would say any connection that you have, utilize it, shadow people, even if it's only for 4 hours, just to be in that hospital setting, to see what kind of decisions they have to make, see how much patient contact time they have, and what, if that aligns with what you want. And I also considered, okay, I have this degree in biology, I could also teach. And so that was sort of my time in Korea. I was like, do I actually really like education more than I thought? And then afterwards it was like, no, I want healthcare. I want to work with patients. I want to work with families, and I want to be a part of working through some of the more intense life decisions that they have to go through. So that's how I eventually came around to it. But yeah, I explored it all. And like Melanie said, like you meet different people and you'll learn from them. And in that process, that's when, give yourself time to make that decision. It definitely makes a difference.
Thank you. That's great advice. Our next question is, can you expand on the difference between the nursing model and the medicine model that you mentioned in the presentation?
Yeah, and jump in, Jess, if you have a better explanation than I do. But I would say, I mean, from the medical standpoint and the way it was explained to me, is that that comes more from a diagnosis perspective. Not to say that MPs obviously still diagnose, but I think a lot of our day-to-day model of a nurse is the kind of compassionate care model. And so we come from a place of sort of seeing the patient as a whole and meeting the patient's needs beyond just medical treatment, although that obviously is part of it. We also treat the person, we sit there and listen. I mean, part of my job right now, I kind of work in a CNA role while I'm still finishing school. A lot of my job is just sitting there and listening to patients talk. And I think that's a huge part of nursing, is making sure your patient feels heard and understood. And if there's something that you can't provide to them, then we connect them with those resources. We get them to physical therapy, we get them to speech therapy, whatever it is that they need. It's sort of like treating the entire patient. And I think a lot of our nursing education comes from that, is like, how can we treat the person as a whole, not just their medical condition? If there's anything I missed, jump in. But I would say that's the biggest difference for me, and why I chose nursing, is because I wanted to practice from a more caring and compassionate standpoint, not just let's treat somebody and, you know, put them on their way kind of thing. So yeah.
Yeah, I would say, kind of going off of that, what I've seen is, so in the medical model, just from sheer like, okay, you go to medical school for 4 years, then you have a residency for 4 years. There's a lot of specific medical information that is great to deal with specific pathologies and looking at like the disease process itself. And a nurse practitioner, a registered nurse, will also be aware of that pathology, but they do have less training in it. And so, but their focus is more, like Melanie said, on the whole person. And so I think if you are someone who really loves biology and you like all the minute cellular details, like the medical route can be totally invigorating and really interesting. But if you're someone who's more like, okay, I know that their cells are doing this, but I also want to talk about like what their family life is like and how that's contributing to making this worse for them, or what we can do to help with their spiritual needs, or are they getting physical therapy, then that's sort of like the more nursing model of that whole person versus sort of the specific disease process in the medical realm. And again, that's my understanding of it. That's kind of what I've seen, but I'm not a medical provider, so.
Great, thank you. So this was also touched on a bit, but what are the pros and cons of being a nurse, and why did you choose nursing over a PA, MD, or DO?
I think the biggest thing for me, and yeah, we did touch on this a little bit, was that I personally like the flexibility of nursing, especially as this being really my second career. I wanted to be really sure that this was the right path for me. And I think kind of knowing that I can kind of move throughout different career paths and not be so locked in was so appealing to me, because, I can still work with patients, but if I decide one day, nope, not geriatrics, I love kids, I want to work with the babies, like that's something I can do. And I just like the flexibility of, of just having that option constantly available. I also liked the autonomy in pursuing NP versus PA, knowing that, I just have a little bit more autonomy, that if I wanted to practice independently one day, I could, obviously depending on the state, but that option was still available to me. And I really want that autonomy. I'm excited to one day be able to actually practice independently and see patients. So yeah, I hope that answers the question. I think it does.
I'd say same difference, NP, PA. I wanted the autonomy, and then MD to NP. Yeah, that holistic approach is more of what aligned with my interests, and that ability to shift. Having options is great. So yeah, that's fine.
Perfect. The next question is, do you feel that there's a big demand for nurses right now with the current pandemic?
Yes. Yeah, a huge demand. Everyone I talk to says you'll have no problem getting a job, which is, you always want to hear that. That's the best thing you can hear. But yeah, I think there is a huge demand. There's job openings left and right in every possible field. It's not going to be an issue.
Okay, great. Our next question is, what are some challenges you faced in the process of becoming a nurse, and how did you overcome them?
That's a good question. I honestly just want to say, like, work-life balance, especially being in like an accelerated program, has been challenging. I also think in terms of just working with patients, like recognizing that you can't fix everything, which is like very difficult for me as a fixer. Like even just the other day, I had a patient that was just kind of like crying about her situation. And I realized, like, I can't fix this, but I can sit here and just listen to her and spend time with her and, ask her about her life. And so I think there's those moments of nursing that's very challenging, where you feel like you have to have an answer right there, or you have to know everything. And that's not true. I think we're all still learning. And I think the best thing that you can do is just be present and be there. And sometimes that's all that you can provide for somebody.
Melanie summed it up great. So.
Okay. The next question is, do you have any advice on how to shadow professionals and gain experience in the nursing setting while in college?
I think you want to take this, Jess, because I think you talked a little bit about shadowing before.
Sure. So some of it was sheer blind emails to people. Like I went to like the career services department at St. Mike's and was like, do you know any nurses? Do you have their emails? Or any people in the healthcare system, do you have their emails? And I would just be like, hey, I'm a student at St. Michael's College. I'm really interested in pursuing XYZ. If there's an opportunity to shadow you, I'd be really interested. And went from there. I don't know how many emails I sent. I'd say I maybe got a response from like a fifth of the people, but that was still a fifth of the people. So I still had plenty of time to explore. I would say professors also will know people that you can shadow. So your career services department and professors that you have a working relationship with, that can also be helpful. And then if you have any family or relatives that you know of that may know people in the healthcare facility or work in the healthcare industry themselves, having that, just sharing with family, yeah, you know, this is something I'm really interested in. If you know of anyone that might let me shadow them, like, please let me know. So my mom is a teacher. She referred me to her school nurse. Her school nurse used to work in the hospital in an oncology unit. And so she referred me to 3 other nurses and a nurse practitioner. And then my stepdad skis with a physician. So it was like a lot of random connections where if you just start sharing with people that it's something you're interested in, people are very willing to help. So it can feel awkward, but just send the email or share your contact information, or just tell people that this is something you're looking to do. I will also note that people in the healthcare industry are busy. So if you specify like, oh, I have a break in February, or I have a break in April, or I have the whole month of August that's available, does this work for you? Giving them sort of those specific timelines can also be helpful, because if they're dealing with a lot of patient cases, the last thing they want to do is try to organize your schedule. So if you can present to them like, I would be available the first week of April, does that work for you? Then it kind of helps them not have to deal with that element of letting you shadow them. Then you can just show up and shadow.
That's great advice. Thank you so much. So we are nearing the end of our time, but thank you so much for this amazing presentation, Jessica and Melanie. For the attendees, we would love to hear your feedback about the session. There will be a short anonymous poll to submit feedback, and it'll be live soon. And other than that, for the attendees, be sure to come back at 11 for our next session, Psychiatry as a Career with Dr. Crystal. Thank you so much again, Melanie and Jessica.
Thank you.
Yes, thank you, everyone, and best of luck.
Bye.
Hello, everyone. My name is Rani, and I'm an exercise science graduate from Rutgers University. I'm thrilled to introduce our next speaker for today, Dr. Crystal. Dr. Crystal is the Robert L. McNeil Jr. Professor of Translational Research, Professor of Psychiatry, Neuroscience, and Psychology, and Chair of the Department of Psychiatry at Yale University. He has published extensively on the neurobiology and treatment of schizophrenia, alcoholism, PTSD, and depression. Notably, his laboratory discovered the rapid antidepressant effects of ketamine in humans. Dr. Crystal is a member of the U.S. National Academy of Medicine and a fellow of the American Association for the Advancement of Science. Today, he will be presenting on the topic of psychiatry as a career. Let us welcome Dr. Crystal.
Good morning, everybody. I'm going to share, see if you can see my slides. All right. Hopefully everybody can see my slides. And I'll be talking to you about psychiatry as a career. What I thought I would do is begin by talking about what psychiatry is like as a profession. Then I'll talk a little bit about my path about psychiatry and where I've come in my thinking about a career in psychiatry. So what is psychiatry? Psychiatry is an area of medicine. And when I say it's an area of medicine, I mean that people who practice psychiatry graduate after 4 years of college, then they complete 4 years of medical school, and then they complete 4 years of training in psychiatry. And then if they want to specialize in a sub-area of psychiatry like forensic psychiatry, geriatric psychiatry, addiction psychiatry, psychosomatic medicine, or other areas, then they have to do a fellowship period after psychiatry residency, usually of 1 or at most 2 years. Psychiatry focuses collectively on the leading causes of disability worldwide. These are the disorders of emotion, like depression, cognition, like schizophrenia or dementia, or social function, problems like antisocial personality disorder, psychopathy, or autism. And there are basically two domains of illness. First, we focus on the treatment of psychiatric disorders like depression and schizophrenia and autism. And we also focus on the neural, emotional, cognitive, and social impact of every medical disorder, a person's reaction to cancer, a person's reaction to heart disease, a person's reaction to diabetes. And so we work in nearly every area of medicine. It's the area of medicine that places a major emphasis on the patient's experience of themselves in the world. And among all areas of medicine, psychiatry is the area that uses psychotherapy as a mode of treatment. Among the mental health specialties, in other words, social work, psychology, psychiatric nursing, etc., it's the only mental health specialty to deal with the entire context of mental illness, the medical part of it, the psychological part of it, and the social part of it. And in this way, psychiatry deals with an extraordinarily broad range of conceptual domains, you might say from molecules to society. And because we work in so many different ways, in so many different contexts, targeting so many different kinds of information, there's enormous freedom in people who pursue psychiatry to pursue different parts of the field at different phases of their career and to change directions if they wish to do so over the course of their career. So as I mentioned, psychiatrists uniquely integrate brain behavior and social functions. And in our clinical work, everything we do stems from our relationship with our patients. our understanding of the biomedical, psychological, social, and social determinants, meaning things like being homeless, being poor, being exposed to terrible things in one's life. So in thinking about patients and drawing on the science, we're thinking about the genetic causes and basic biological mechanisms of illness, basic brain functions. We're interested in how the circuits of the brain that support behavior are altered in the context of psychiatric disorders. We're thinking about how to use ways to change the brain directly through the prescription of medications and through the application of brain stimulation techniques to change the activity of brain circuits and thereby alleviate symptoms and suffering. And we're thinking about how to use psychotherapy, our discussions with individuals, with their families, and with groups of people to try to help them in their recovery. And we also try to attend to and support community-based interventions and the practical issues like housing, disability pensions, and other factors shaping social determinants of their health. So we deal with very broad areas. Now, when you think about the equipment of psychiatry, you might say old school, that basically a lot of what we do in psychiatry, perhaps up until COVID, involved notepads, pens, and comfy chairs to have good discussions. But the field actually is incorporating a variety of new kinds of technologies to help us to better understand the brain, to help us better assess patients, and to help us to better treat patients. And some of these new technologies are brain imaging techniques like MRI, positron emission tomography, EEG, magnetoencephalography. And some of these brain stimulation techniques include electroconvulsive therapy, transcranial direct current stimulation, and transcranial magnetic stimulation. So I mentioned that psychiatry, in psychiatry, you can have many different kinds of careers. Now, many people are most familiar with the notion of psychiatrists working in an office, treating patients with medications and psychotherapy. In other words, the private practice model of psychiatry. However, there are all kinds of settings in which psychiatrists work, inside hospitals, in inpatient psychiatry units, working in hospitals and clinics where we're consulting to medical and surgical patients, working with the courts and the prisons in an area we call forensic psychiatry, advising governments, providing outpatient care, educating the public, working with the pharmaceutical and biotechnology industry to develop new treatments, conducting research in academic medical centers, teaching. We do a lot of different kinds of things in psychiatry. So why do people like pursuing careers in psychiatry? First, the work is incredibly interesting and very rewarding. I would say it pays well enough. It's sort of in the middle of medical specialties. Certainly certain kinds of doctors like surgeons make more money. Others, I suppose, make less. As a lifestyle, it's a good lifestyle. People have a lot of ability to control the hours that they work and the kind of patients and kind of context that they work with. There are many different kinds of career paths. There's the potential for flexible scheduling for parents. And there are some challenges in psychiatry. First off, it's the area of medicine where there's probably the greatest shortage of doctors. So there are often many, many more people. If you're a doctor in private practice, many, many more people seeking your help that you could treat. Oftentimes, working in hospital and clinic settings, the services that you can offer may be determined or shaped largely by reimbursement. that patients get rather than by what they need. And so there's a paradox, which is that while psychiatric problems often lead people to be out of work or to be disabled, that paradoxically, psychiatrists, many of them in private practice, are treating a group of people that are sometimes called the worried well. In other words, people who have all the resources and can pay out of pocket instead of using their insurance or their public disability payments. Some people find that doing the work of psychiatry is very emotionally demanding. Clearly, in psychiatry, when we're doing psychotherapy and interacting with our patients, that there can be, you're dealing with people at very difficult periods in their lives, and that we're dealing with people on very difficult issues, emotional distress, family difficulties, and some of our patients in a long career in psychiatry, some of your patients will eventually commit suicide, and that's obviously can be very upsetting. But I would say overall, it's a very rewarding career, and most of the time you're dealing with helping people to make positive change in their lives. So what can you do in college to prepare for psychiatry? You need to take the pre-medical school requirements, like anyone going to medical school to become a surgeon or an internist. It's good to learn about psychology, and you can do that by taking classes in psychology in college. You can read books about psychiatry, and you can get experience in the field of psychiatry or psychology by getting involved in research at a medical school or academic medical center, or more locally for some people to shadow a psychiatrist in a hospital or clinic-based. If there aren't psychiatrists in your area, psychiatric nurse practitioners or psychologists would also be good people to schedule to try to get a feel of the field. I hope you'll take the idea of a career in psychiatry to heart, because we need more psychiatrists, and we particularly need more young psychiatrists who bring new perspectives into the field. And so I hope you'll think about that. So I'm going to switch now to talk a little bit about my path in psychiatry. This is a picture of me when I was a senior in college. And I was at a meeting, the American Psychiatric Association meeting, where I had the good fortune to actually join my father, who was a psychiatrist as well, in the setting. And when I think about two influences when I was in high school and early in college who had a big impact, one was my father, who was a psychiatrist, from whom I learned a lot about ways of thinking about careers in psychiatry. And the other person who probably had a big influence on me before I got into college was Miles Davis, who was a famous jazz trumpet player. I was very involved in music in high school, and I tried to play trumpet in the style of Miles Davis, although of course I failed in achieving anything like the accomplishment that Miles Davis had. But my involvement in music got me very interested in the problems of addiction, because some of the people that I was in bands with in high school and college developed addiction problems. And so when I started out in college, I looked to try to get some exposure in the way that I mentioned. And I started volunteering at a methadone clinic, and I got involved in an academic program in a methadone clinic that was connected to my college. And when I was in college, I learned that that there were chemicals in the brain called endorphins that acted just like methadone and bound to the receptors for these opiates like morphine or methadone called opiate receptors, and that there were whole chemical systems of the brain, therefore, that were responsible for the development of physical dependence on opiates. And for me, there was, it was like a moment of epiphany. I had this insight that the thing that most fascinated me about the work was the connection between the very basic level of neuroscience and brain science and the problems that patients that I saw in the clinics, methadone clinics, were having. And this process of linking basic neuroscience to the clinical practice of psychiatry is called translational neuroscience. And I developed that passion in college, and that has been, in some ways, the main organizing principle for my career. When I graduated from college, I came to Yale for medical school. And the reason that I came to Yale for medical school was it seemed to be a good home for somebody who had the kinds of interests that I had. That is, connecting the very basic levels of neuroscience to clinical practice. And the reason that what they had done that made it seem like a good place was to develop the first non-opiate treatment for opiate withdrawal, which was called clonidine. And the idea that they discovered at Yale, was that nerve cells in the brain possess both receptors, the opiate receptors, and another receptor called the alpha-2 noradrenergic receptor, which is a receptor stimulated by clonidine. So that in opiate-dependent tissues, if you stop taking methadone or heroin or morphine, the neuron would get very activated, and you could suppress that activity by giving clonidine. Clonidine was then shown to suppress withdrawal symptoms in animals and to suppress withdrawal symptoms in people. And this was the first time in the entire history of psychiatry where somebody had worked out a very basic neuroscience mechanism and taken it all the way to a new treatment. So I figured this would be a good place for me to go, because I wanted to do something like that. In some ways, and this is me in medical school, my friends and I did a lot of rock climbing. And so part of me was looking for adventure outside of the medical school classroom. But a lot of what I was also doing was looking for adventure in my science. I was looking to find areas that we didn't understand and to see whether by exploring those areas that we didn't understand well, whether we could come up with new treatments for psychiatric disorders. After finishing my psychiatry residency, I joined the faculty. And I had never done schizophrenia work before, but when I joined the faculty, I decided to work in the area of schizophrenia for a while. And it went something like this. My boss said, "Do you want to be the director of the schizophrenia unit or the deputy director of the PTSD unit," which was an area that I also was very interested in. And I said, I'll take schizophrenia. I don't know if it was a smart decision, but I thought I wanted to be in charge. And in order to be in charge, I had to study schizophrenia. And that, in a nutshell, is how I got involved in schizophrenia. But as I started learning more and more about schizophrenia, I realized that I wanted to figure out how I could have a kind of distinctive impact through my science. And I'll call that, for the purposes of our discussion, a hook. And the hook was that at the time, most of the field of schizophrenia focused on a chemical system called dopamine. And the dopamine cells live in a primitive part of the brain called the midbrain, and tune the activity of higher brain centers, the cortex and the basal ganglia. It seemed to me that the pathology of schizophrenia did not live in the primitive centers of the brain, but lived in the highest centers of the brain. And because they lived in the cortex and the basal ganglia and limbic system, That meant that the biology of schizophrenia involved a different chemistry, not the simple chemistry of the dopamine cells, but the chemistry of glutamate releasing cells. Glutamate is the main excitatory transmitter in the cortex. And I decided that I would shift the entire direction of my work to focus on the glutamate system. And that brought me to a drug that I could use to give to people to test the integrity of the glutamate system of the brain. That drug was an anesthetic medication called ketamine, which is also a drug of abuse. And the remarkable thing that we found when we administered ketamine to healthy people in very low doses that didn't make them go to sleep like surgery was that this drug transiently, briefly, produced symptoms that resembled the entire spectrum of symptoms that we would associate with schizophrenia. The positive or psychosis-like symptoms, things like hallucinations and delusions, but also the negative symptoms, the emotional blunting, the detachment, the lack of experience of pleasure, as well as cognitive impairments that were disabling. All of these effects produced by ketamine resembled in some ways what one would see in schizophrenia. To make my career a very long story short, what we did then over the next 30 years were to find the best technologies that we could use, the best techniques that we could use, and the best teams of collaborators that we could build in order to ask the question, why does this simple drug, ketamine, produce effects in the brain that result in behaviors that look like schizophrenia? And here's one example of what we found out. My colleague, Amy Arnsten, found that a drug very much like ketamine could affect single units in the brains of non-human primates involved in a cognitive function that's impaired in schizophrenia called working memory. When a monkey tries to keep information online, it activates certain neurons in the prefrontal cortex, and those neurons stay active as long as the information is kept online, and then those neurons guide action and go offline. If you block the glutamate receptor, you prevent this activation. Now, we're not recording the activity of single neurons in the brain with electrodes in healthy people. We're using functional magnetic resonance imaging to show that these populations of nerve cells are activated during the encoding of working memory, and then the activity goes away after they act based on that memory. The NMDA glutamate receptor blocker, ketamine, reduces this activation, contributing to cognitive impairments like impairments in working memory. And this is relevant to schizophrenia because while healthy people activate this part of the prefrontal cortex with working memory, people with schizophrenia show reduced activity as if they had gotten ketamine. But no, they're not getting any ketamine. This is their intrinsic biology. And then we can use high-level computational neuroscience, mathematical modeling, to identify certain weak points in the circuitry that might account for why we see these patterns of neural activity. And we've made these bridges which help us to understand why the drug effects resemble the symptoms of the disorder. And what that has led to is new insights into the neurobiology of schizophrenia, focusing on disturbances in the activity of certain very micro circuits in the prefrontal cortex. This has enabled us to incorporate information from many different areas of research, such as molecular genetics, which help us to understand why these abnormalities in circuits develop in schizophrenia that resemble the effects of ketamine. It has led us to test potential new treatments for schizophrenia that we wouldn't have otherwise thought about testing, because we are trying to ameliorate or prevent the circuit dysfunction that ketamine produces. I should say that use of ketamine, which, as I mentioned, is an anesthetic medication, but also a drug of abuse, that it turned out to not be popular with a lot of people, that we were studying the effects of ketamine with people. Some people thought that it was risky to give a drug to people that briefly produced symptoms of dissociation or psychosis. And several advocacy groups were concerned about this. And that led to newspaper articles raising concerns about the safety of ketamine in research. Those articles appeared in important places like the New York Times and the Boston Globe. In response to the concern, Yale instituted several levels of review. They reviewed my research, they reviewed my documentation, they reviewed that, and other institutions reviewed people who were doing ketamine research at other institutions. And the main funding agency for a while did not fund research on people giving ketamine to test its effects. And ultimately, Yale asked the director of the National Institute of Mental Health to come and review all of my research. And the upshot, though, was that my research program was very strongly endorsed, and I was able to continue my research. And that ended up being a good thing, because the next thing we tested was the antidepressant effects of ketamine. And that led to the identification of ketamine and a new drug called S-ketamine as the first rapid-acting antidepressant. Let me say a little bit about depression, because many of you may think that depression is like having a bad day, and that not many people really struggle with it. But the reality is it's a very common problem. At any given time, around a little less than 10% will meet formal diagnostic criteria. 10% of the population, 1 in 10 people, will be depressed. So there are 100 some odd people on the call that would suggest that in their lifetimes, maybe up to 10 of us or more will have depression. Depression is one of the leading causes of disability in the United States and worldwide. It's also, as I mentioned earlier, a lethal disorder in that some people will commit suicide, but also because depression is part of changes in your entire body, including a process called inflammation that can contribute to heart disease, lung disease, other diseases, that if you have an index of depression, episode of depression, and particularly if that episode of depression is not treated, that it can shorten the length of one's life. The other reason that I wanted to get involved in depression, because antidepressants, the standard antidepressants, turned out to be less effective than we hoped. That in general, between 1 in 2 and 1 in 3 people treated with an antidepressant will respond. And at the end, typically about a third of people will not respond to the standard medications. And when they respond, if you're one of the people who respond, it can take a few months to respond. And if you are one of the people who doesn't respond very well to medications and you ultimately get to a response, there's a good chance you'll relapse. So there was a need for medications that were both more effective, that worked more rapidly, and helped to prevent relapse. So this is where we took another conceptual leap. And the conceptual leap was to view depression from the same perspective that we brought to schizophrenia. That in the case of depression, we were focused on other systems in the brain in depression the serotonin and norepinephrine system, but we were brought back to thinking of depression as a disorder of the cortex and limbic system rather than the primitive parts of the brain. And our thinking led us back to glutamate as a neurotransmitter and led to us testing ketamine effects in depression. So remember that I said that the average antidepressant can take about 2 months to really kick in. What we found when we gave a single dose of ketamine to patients with depression was that within about 4 hours, people were feeling a little bit better. And some patients within 24 to 48 hours were all better. In other words, that their depression had completely gone away. This was a completely shocking observation to us and ultimately to the field, but it helped us to appreciate that by going in new directions, targeting new aspects of the biology, that we might identify treatments that had been both unexpected and which were effective in ways that we couldn't have anticipated. Now, Time magazine has called ketamine the antidepressant. And I think that's really, in some ways, an apt idea, because first of all, because it was so unexpected, and second of all, because it has led us to think about really new and exciting aspects of the biology of depression. And to boil this down in very simple ways, one idea is that the glutamate system itself is abnormal in depression in two fundamental ways. The first, which we could test with a technology called carbon-13 magnetic resonance spectroscopy, is that that glutamate synaptic connections in the brain are less effective. So that instead of when a molecule of glutamate binds to the glutamate receptor, instead of evoking a big response, it evokes a small response. In other words, the neural communication is less efficient. Another and equally kind of striking finding was that we were able to identify, using a different technology called positron emission tomography, was that not only were the synapses less effective, but there were fewer of them. In other words, that there was a reduction in the density of glutamate synapses in the brains of people who were experiencing depression. And you could show in animals that these synaptic connections, these arrows marked here by the arrows, are reduced in animals that are stressed, and that a single dose of ketamine in a stressed animal will cause the synaptic connections to regrow. So you're not only affecting the functionality of brain circuits, but the illnesses are affecting the structure of these brain circuits, and the treatments are similarly restoring or normalizing brain structure. I'm going to skip through this slide relatively quickly, because I think in the end, I'm just going to make one other point here, which is that there are other treatments that may target the regrowing of dendritic spines. And one of them, which works in a different way, is called psilocybin, which is a hallucinogenic drug, but it also has the potential to activate brain circuits and to regrow these synaptic connections. This is just results from a study that was recently published by another group suggesting that psilocybin may also have antidepressant effects. So in closing, I'd like just to share some big picture thoughts about psychiatry and a career. First, find your passion, whatever that is, and pursue it. Choose a good home to pursue that, a place where people will support your interests. Find your adventure. Everything that you do should be exciting and fun and help you to stay connected to your passion. Think about, what's your angle on this? What's your hook? What is the problem that really reaches out and grabs you? And how could you get involved in a way that feels important and meaningful to you? If you're lucky enough to find that, take the leap, just get involved, get started somewhere. Whether it turns out to be the right path or not doesn't matter. It will sort out. And over the long haul of your career, pursue the things that seem important to you, whatever they are, and stick to your guns, because in every career, there are going to be moments that are very challenging, where you face unexpected obstacles or disappointments, like when we had to deal with the concerns about the safety of ketamine. But if you stick to your guns and stay open to new adventures, you may just find things that you don't expect, like the antidepressant effects of ketamine. I've told you this story as if it was a story about me or just about me, but it's really about teams, about people who've worked together. And these are all people who were involved in the research or helping me to figure out a path that I wanted to go in my career. And I'm incredibly grateful to these people, including our patients, our families, and the context that we worked in. I just wanted to say one thing about academic psychiatry, which is a particular passion of mine, which gives you all kinds of great opportunities, like interacting with remarkable colleagues, traveling the world, collaborating with people around the world, editing journals, advising organizations and governments, leading professional societies, and things. And I'd like to make one other point, which is useful just to store away, which is at your stage of your career, you will find that your career is all about you. Who am I? What do I like? What do I want to do? What should I do? How should I go there? How can I make connections? And what happens over a career is that it shifts to being not so much about you, but about the bigger picture around you, creating a legacy in your field, fostering the careers of young people, building organizations, and helping society. So what doesn't change is this excitement of discovery, the quest for deeper understanding, the meaningfulness of work with patients, the stimulation of challenging yourself and trying to learn new things, the pleasure of teamwork, and the thrill of discovery. So with that, I'm going to stop my screen share and maybe we can take some questions.
All right. Thank you so much for all your wonderful insights and the lessons you shared with us, Dr. Crystal. So we will now take a leap into our Q&A session. And attendees, please feel free to use the raise hand feature if you would like to ask the questions live. So let's go ahead and see our first question, which is, what is the difference between psychiatry and psychology?
Okay, that's a great question. So psychologists go to college. You often, but not always, major in psychology and apply to PhD programs, graduate school programs in psychology. So a psychologist is a PhD, not a medical doctor, but often very well trained in both research approaches and in psychotherapeutic techniques. And a psychiatrist is an MD doctor, in other words, can practice medicine, prescribe medications, and does additional specialization in psychiatry and can prescribe medications, but may not have the same training that the psychologist has, particularly in research methods, unless they pursue that.
Awesome. Thank you for clarifying that, Dr. Crystal. Our next question would be, would you recommend someone joining the psychiatric field if they have had a history of mental illness?
If they have had a history of mental illness. So the way that I look about it is, it's very similar to asking if it would be appropriate to enter the field of orthopedic surgery if you broke your leg. In other words, a history of mental illness as long as that mental illness is well treated and managed, and you're okay and able to do what you need to do, then I think it's fine for people who have a history of mental illness to pursue um, uh, uh, psychiatry. It's about 1 in 3 families have someone in them with mental illness. If we ruled out people who came from families with mental illness, we'd rule out almost everybody in the country. So we can't afford to do that. We need people who either have personal or family experience with mental illness, to some of them anyway, to go into psychiatry. And sometimes those people bring unique insights that are helpful.
Awesome. So, what are some habits or mindsets that have empowered you in your psychiatry journey?
So, I think the one that that I would say first and foremost, and I tried to allude to it with the picture of me rock climbing, is that I love adventures and I love challenges. I love diving into things that are mysterious to me and learning about them. And so I find my career, I've been doing this on the faculty for 40 years. I continue to be excited about coming to work every day to try to do this work. The second thing I would say is that I find the problems that people are struggling with, depression, anxiety, psychosis, cognitive impairments, I find those to be incredibly meaningful problems. And so I like to talk to people to hear about what their problems are, about their painful emotions, their difficult experiences, because when I can help them manage those situations, I feel like I've done something very important for them. I think this is one of the things that I learned from my father, which is that sometimes it's more important to focus on things you can do to help someone feel better about themselves and their lives than to say, just extend their lives. If that the quality of life is really important, and psychiatrists do a lot to help people with the quality of their lives.
All right. And for our next one is, how does psychiatry differ from behavioral neuroscience?
Well, psychiatrists and neurologists are the main types of doctors that work in behavioral neuroscience. So there's a sub area of neurology called behavioral neurology, and there's a sub area of psychiatry and that's called neuropsychiatry. And those two groups of people do essentially exactly the same thing. And they're so similar that the behavioral neurology and neuropsychiatry societies meet together. And that's because in psychiatry and in medicine, and I mentioned the enormous flexibility that we have, that often people define themselves by what they do, the kind of patients they treat, the kind of approaches they use. And you can use many of these approaches in neurology and in psychiatry. Behavioral neuroscience is the broader field of studying aspects of the brain that affect behavior. And that's very relevant to both neurology and to psychiatry.
Thank you. And where do you recommend finding research opportunities in neuroscience?
So I would start in the places that are close to you, where in your college, talking, this is the way that I'll just start out by tell you the path that I did, which is I just started, talking to people. One of the little tiny pictures on my screen was a picture of a psychiatrist at my college, a guy by the name of Danny Friedman. And when I discovered the endorphins, I thought that was the most incredible thing, and I had to get involved in it. But I had no idea about how to get involved with it. I didn't even know who to talk to. So I just made an appointment with the chair of the Department of Psychiatry. You might say it was kind of bold of me to do that, but I just asked him, who's doing this kind of work? And he was incredibly kind, and he directed me to a laboratory that was doing that kind of work, and that's how I got connected. So I didn't know anything about it. My dad didn't know anything about it. I didn't know anything about it, but I just kept asking questions until someone could direct me to the right place.
Thank you, Dr. Crystal. And can you speak more on misunderstood neurology disorders like ADHD and the resources on how to manage these disorders while pursuing a profession? What programs are available for students?
So is the question about how to manage their own ADHD, do you think?
It would be if you were in the medical profession.
And you
and
had
helping
ADHD?
others.
Or you wanted to help people who had ADHD?
Yes.
So there are many ways to, so one of the great things about mental health and psychiatry, neuroscience, is that there are many paths, many career paths. So I know people who work in ADHD who are social workers, who are psychologists, who are psychiatric nurses, who are psychiatrists, and who are neurologists. And they all are brought together because they are think ADHD is a very important problem. Neurologists and psychiatrists tend to be involved in the clinical assessment and prescribing of medications. Psychologists and social workers may be involved in the school and family problems or psychotherapy. There are also now some cognitive training techniques, computer games that you can play to work on improving attention. But you can pursue a variety of different careers and still be involved in either the research or the treatment of ADHD.
Okay, thank you. And are you familiar with or have you done research on the relations of neuroscience and music, or the effect that musical rhythms have on neural movement?
That's, I think, a really interesting question. And particularly interesting because so many people, myself included, find listening to music very soothing and relaxing. And there are people who are doing research on the neural basis of music appreciation and the way that music helps people to relax. So there are people who do that. I don't happen to do that, but I think that work is interesting.
And when diagnosing patients, how often are they misdiagnosed or have multiple disorders? What disorders show the most comorbidity?
That is a very sophisticated question. So this is one of the things that I didn't talk about is the complexity of psychiatric diagnoses. And one of the sources of complexity is that so far, psychiatric diagnoses are made on the basis of reported symptoms and difficulties. In other words, if you use opiates, you have opiate use disorder. If you are depressed, you have major depression. If you have hear voices and have difficulty focusing at work, you may be diagnosed with schizophrenia. So we don't think the brain works in such discrete ways like that. And so our diagnostic manual often doesn't fit the real world. And one of the reasons it doesn't fit is precisely the issue that oftentimes people will have multiple problems at the same time. So they may, for example, they may have post-traumatic stress disorder, something terrible that they witnessed in their life. And along with their post-traumatic stress disorder, they may become depressed. Now, is that depression a separate disorder, or is that depression part of their post-traumatic stress disorder? That's a really complicated question. But there are some clues that depression in the context of post-traumatic stress disorder may be a little bit different biologically than depression without post-traumatic stress disorder. Now, that same person who has PTSD and depression may also drink too much. And so they may have PTSD, depression, and alcohol use disorder. That's the real world of complications, but it's very important to appreciate the common comorbidities, as we call them, because when I meet someone who has PTSD and gets the diagnosis but doesn't have a drinking problem, we talk a little bit about how people with PTSD are at risk for developing problems with alcohol and drugs, with the idea that if we can prevent those expected comorbidities, that people will be better off than if they develop them, and then we treat them. Yeah, I think I'll stop there.
Thank you, Dr. Crystal. So what is something that you wish you had done differently in your career or life?
Yeah, that's really a great question. I mean, there are things that I did that made no sense in my career. And I often tell my trainees that I am the absolute worst role model, because so many things that I did made my life harder at various early points. And so I would say that a lot of what I did is just jumping into things, sometimes without enough preparation. And nowadays, when you go through, if you know you want to have a neuroscience research career and you know you want to be a psychiatrist, now it's much more likely that you might do either a PhD along with your MD, or you might do a postdoctoral fellowship on top of your residency training to get deeper research background. I didn't do that because I just jumped in and did research. And I think that made it harder and more stressful. So appreciating how much preparation you need to do research and giving yourself the space and the time to get the training, I think that is something I would strongly advise nowadays, because research has gotten harder, more complex, and you need to know more than when I started out.
Yeah, I agree. And what differences have you found between your work in research and your work in with patients? Is one more meaningful than the other?
It's very hard for me to say. I mean, I still see patients and I still do research. I can't imagine giving up seeing the patients. I have some patients that I've treated since 1992, and that may be before someone on the call might be born. So you develop the relationship in treating patients is really meaningful to me. But I also can't imagine giving up research. Research is probably the thing that most gets me excited when I come into work every day, and building programs that support research activities. Because I think in psychiatry, I was always very impressed by the limitations of what we understood. And wanting to do something about that seemed also really important. And making little steps of progress, like what I showed today, it's all been so exciting. I would do it all over again, starting all over from the beginning if I could.
Thank you, Dr. Crystal. So how encouraged is experimentation in the field of psychiatry?
Well, I don't think there's an overall state. I think in academic medical centers, it's very encouraged. In community clinics that often don't have the infrastructure to support research, it's less common. So finding the good home for what you want to do, that I do think is an important part of getting to where you want to go.
And are you optimistic that there will be a larger supply of psychiatrists in the future, given the increased awareness of the importance of mental health?
I certainly hope so. We need you. Please come to psychiatry.
All right. And did you always wanted to be a psychiatrist, or did you have any other career dreams in the past?
Well, when I realized that there was no way I was going to be a professional musician, I thought psychiatry. Well, I guess it for me a critical moment was in medical school. I knew I wanted to do something neuro, and I got a chance to try neurology, which I like a lot, and neurosurgery, which I like being uh, connected to. But I don't have the temperament of a neurosurgeon. A neurosurgeons have to be really, really patient and really, really detail oriented, because if you go off, if your mind drifts off and you cut out the wrong part of the brain, that's not a good thing, generally speaking. So I realized that my temperament was good for the kind of research that I like to do, and I would say that as a general rule, that knowing yourself and and choosing kinds of work that are congenial to the way that you like to work, that's a good fit. In other words, doing things that you actually like to do, as opposed to things that you think you ought to like to do. That is an important distinction.
Thank you so much, Dr. Crystal. And that brings us back to the lessons that you shared with us earlier. And unfortunately, we have to cut off our Q&A session for now. But thank you, Dr. Crystal, for your time. For the attendees, please stay tuned for Dr. Wynn's presentation on exploring competitive specialties as an underrepresented student. And we will also have a survey. Thank you.
Thank you very much. It's been a pleasure.
Hello, everyone. My name is Angela Bruce. I'm a student at the University of Minnesota and one of your NPHC hosts. Today, I have the pleasure of introducing Dr. Wynn, a director for Johns Hopkins JUMP program. Johns Hopkins Underrepresented in Medical Professions, JUMP is a collaborative program whose mission it is to promote the success of students in underrepresented populations. Dr. Wynn's session today is dedicated to encouraging underrepresented pre-meds to explore and consider competitive pathways before entering medical school. Let's welcome Dr. Wynn and her guest speaker, Dr. Oakley.
Hello, can you guys hear me? Perfect. All right, let me go ahead and share my screen. And for this presentation, we are also going to be using a Pear Deck. And so if you can go ahead and go open up a new browser tab, or you can do it from your phone, joinpd.com, and put in this code EDPQGF. We can also stick it in the chat for you. So we will wait as students get connected, and then we will do some additional introductions. All right, I see students getting connected. Again, you're just going to joinpd.com, and then you are putting in this code. And we will wait for a few more students to join. So joinpd.com, and the code is EDPQGF. Okay, so I just dropped it in the chat. We will go ahead and get started, but you can still join the presentation at any time. I want to first thank the National Pre-Health Conference for having me back to speak. I really enjoyed it last year, and I hope some things I'm going to say are helpful today. I also have a very special guest with me today, Dr. Francesca Oakley, who is a physician and assistant professor of pediatrics in neonatology, pediatrics, and at the University of Maryland School of Medicine. We are going to be doing an interview with her just a little later, so I'm going to hold off on her introduction because I'm going to ask her to do that when we reach that point in our presentation. So one of the reasons why we wanted to come present to you today is certainly we're not promoting this route, right? But we do want to encourage that if you are an underrepresented student, we're going to see more about as we dive into the data, that this is on your radar and that you feel comfortable and confident that you can go down this road, that you can explore some of these different specialties, and you're exposed to some of your different options, right? So let's take a look at our session agenda. So we're going to do a little data exploration in a second. And then we want to hear from you about what are some of your current and past experiences as far as exploring competitive specialties. Then we're going to have our interview with Dr. Oakley. And then we're going to go into some ideas, and then Q&A is open, and you can ask us anything during that time. Okay, so first, I just want to, start and just continue what I was saying before. As we're not saying any specialty is like better over the other. What we're saying is that if there is something and you're like, oh man, this feels unattainable, we just want to encourage you that you don't have to wait for the stars to align. You don't have to wait to wake up one morning and say, you know what, I think I want to be a dermatologist, right? You don't have to wait on that. You can start exploring now, and there's absolutely nothing wrong with early exploration, right? I love this quote from Pharrell where he says, don't wait for the stars to be aligned. Reach up and rearrange them in the way you want. You can take ownership and control over your journey and over your pathway into medicine. You can create your own constellations, right? I saw that a student posted something up on social media that said, I really want to go into the specialty, but I see there's like only a handful of us, and that makes me nervous. It's like, join the handful, right? Like they need you, be a part of the handful, and maybe then you're going to encourage more students behind you to enter that specialty as well. Okay, so before we get started, I just want to have some shared language and what we're going to be referring to as like competitive specialties and how those are usually characterized, right? So those can be characterized by the high number of applications that are received relative to the number of open residency spots, right? They sometimes can include an additional rigorous screening process. Sometimes they do want you to have higher test scores or board scores. Sometimes it comes with a higher level of commitment to the specialty early. So they want to know like how you have been working towards this goal to enter this specialty. It often is characterized with longer residency and training. And then usually there's higher pay involved with that, right? So now that we know what we're kind of going to be referring to within competitive specialties, let's look at the population that we're kind of targeting and talking to. So underrepresented in medicine. So we are going to be using the AAMC definition of underrepresented in medicine today, which means those racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population, right? So this historically includes American Indian or Alaskan Native, which make up 0.3 of US physicians, Black or African American, which make up 5% of US physicians, Latinx or Hispanic, which make up 5.8%, and Native Hawaiian or other Pacific Islander, which make up 1%, okay? So that's, when we're looking at data, those are the numbers that we're looking at. Okay, so let's move in and look at some data. So this is the first chart I pulled directly from the AAMC, and this shows primary care physicians by race and ethnicity, and this is pulled from 2018. So what we are seeing here is this is the percentage of physicians, and then we have race and ethnicity here. And at a glance, what we're seeing is URM physicians in comparison to non-URM physicians tend to dominate primary care specialties a bit more. So we see Black and African American, Hispanic, American Indian or Alaskan Native, and then Native Hawaiian or other Pacific Islander, right? That those tend to be specialties that they move into more often than their counterparts, right? And let's take a look, let's do a deeper dive into some of these specialties. So there are a lot more primary care specialties than just this. In the interest of time in this presentation, I just picked out 7 just so we can take a look at. So this chart is showing specialties by length and training and pay from 2020 and pulled it from a couple different sources. So if we look here at some of these primary care specialties, what we're seeing is shorter residency lengths, right? And there's a huge benefit to being in residency shorter, right? You get into residency, which means you get out a little quicker and you're able to start making money sooner, right? So you get a paycheck sooner. If we look here, also another benefit is you can start, in your own practice a little sooner and working directly with patients without, oversight a lot quicker. And then we look over here in this last column and we see salary estimates. Now, I want to preface salary estimates. You could Google salary 5 times and come up with something different every single time. A lot of this is also dependent on where you live, where you're practicing. Are you in private practice? Are you in, in academic medicine? Like it varies. We're just getting an idea. So we have kind of shared language surrounding this. So what we see is, relative to the general US population, right? This is certainly a lot more money than someone would make. But when we compare it to surgical, right, specialties or subsurgical specialties, it is a bit lower, right? And so that's what we're looking at here. So let's take a look at that. So these are non-primary care physicians. So this was also pulled from 2018. And when we look at these numbers, what we're seeing here are the numbers then flip, right? Like if we look at underrepresented in medicine, here's Black or African American, so that went down a bit lower. Hispanic, Yeah, relative to non-URM physicians, lower, American Indian or Alaskan Native, lower, and then Native Hawaiian or other Pacific Islander, right? So these are all kind of grouped together, but we're going to dive a little deeper into the next slide. So let's take a look at some shared language surrounding what we're talking about in terms of surgical subspecialties or like a little bit more competitive specialties. So this is also by length of training and pay. So what we saw on the last slide, right, was like 3 years, 4 years. These are longer, right? We're seeing 6 years, 5 years, 5 to 6 years, 4 limbs and a prelim. So definitely longer. So that means you're not getting paid what you would be getting paid on the right-hand side of the screen. You are still, like, while you're in training, you have oversight, right? Your training is definitely more specialized, right? And that's what you're doing. And that usually comes with a higher salary. So as opposed to the figures that we saw on the last screen, these salaries are definitely higher, right? But it comes with the territory as far as your training goes. Okay. So just some shared language. Ones we picked out here: dermatology, neurological surgery, ophthalmology, orthopedic surgery, otolaryngology, plastic surgery, and then radiation oncology are some of the ones that we picked out here. I probably should go back and just say, yes, if we look at these ones, these are generally categorized under primary care. So family medicine, internal medicine, geriatrics, OBGYN, peds, PMR, psych. Okay, so now I want to take a look at, so now we're going to go even deeper, right? We want to take a look at who is dominating these particular spaces for competitive, like surgical non-primary care specialties, and then also how that looks for, and how it also looks for primary care. So let's start with primary care, right? If we look at primary care specialties, based on race and ethnicity, and this is pulled from 2018. Oh, sorry, I should have changed that, 2019, excuse me. And if we look here, we see that none of the numbers are particularly great, right? So I want to preface that. However, we've got some double digits on this page, right? So we see like family medicine, we're like almost at 13%, geriatric medicine, 15%, 12%. So the number, like, although not fantastic, we do have some double digits here. Now, still not great if we look in comparison to non-URM physicians, right? And then other or unknown, that's either the person wasn't comfortable reporting, or they might have fallen into several different categories, right? So I just pulled it out for the definition that we're using today. Yeah, so we can just kind of see here, the numbers are a little higher. When I flip to the next slide, we see the numbers get lower, right? We don't have any double digit numbers here. We're looking, we've got derm like 8%, neurological surgery 9%, otolaryngology, which is ear, nose, and throat, like 6%, rad-onc 7%. So, and if we look at our non-URM, at the non-URM counterparts, there is a drastic difference, right? And so really all of these specialties need more underrepresented individuals going into them, but there is definitely a particular need to take a look at how are students being encouraged or maybe discouraged from entering into some of these spaces, and what can we kind of come up with today to give you some ideas about how you might go about exploring this so that it is on your radar when you get to medical school during your first couple of years of medical school, and you feel comfortable saying like, you know what, I want to explore derm. Like, I know that, you know, maybe there's not a lot of people in the specialty that might look like me, but I've always kind of been interested in skin and healthcare. Maybe you've dealt with skin issues in the past. Keep it on your radar. You are absolutely needed within these spaces. Okay, so let's talk about some of your own experiences, and this is where we want to hear from you. So using Pear Deck, so if you're just joining, you can still go to joinpd.com and put in the code that you see on the upper right-hand corner of your screen. And Dr. Alcoli and I were curious, as a URM student, are you more aware or knowledgeable of primary care specialties or surgical subspecialties, both or neither? So I see some responses coming in, so we're going to take a look at this. Get a few more. All right, let's see. All right, we'll kind of watch this as we come. So a few students, primary care. I am knowledgeable about my options for both. So that's a really good sign that you're considering things. But we have just as many students who said that said I am not knowledgeable about either option, right? So also, okay, great. Let's move on to our next question. Okay, now this is a question where you're going to have to type. So what do you think are some of the reasons for lower numbers of underrepresented and medicine physicians entering competitive specialties? I want to see, what do you think are some of the reasons for some of the numbers we just saw on that last slide? No right or wrong answers here. We just want to see, and we know that Dr. Okoli will be probably addressing also some of this and sharing her own story about her experience with this. So let's see what you are saying here. Yes, so financial reasons might need a quicker path to income and knowledgeable mentors available. Yeah, remember when I talked about your training almost doubles sometimes, right? We go from 3 years to 6 years, right? And sometimes even past that if you're going to do a fellowship. Less opportunities for URIM, less availability of information. Access to information, lack of representation, mentorship, yeah. I believe that people may think it's unattainable because of the competitive field and finances. Yep. Yep. So I'm seeing a lot of things surrounding financial support, less opportunities for networking within family. Yeah. So it's hard to shadow, right? If you can't just pick up the phone and call, someone who's who's an otolaryngologist and say, yeah, can I come in on Saturday and or Thursday and shadow you? Yeah, fear of being judged, less connected to people, being discouraged, not aware or expensive process. Difficulty in affording school. Yeah, a lot of financial, lower scores, longer residency period, sense of not belonging. Yeah, remember when I said don't be afraid, enter the space, even if there's not a lot of you. Not everyone's comfortable doing that, right? And sometimes that can feel really lonely. And so we also need to respect that some people might not feel, as comfortable. Less support, likely to be first generation. Yep, no support, lack of funds. Too long of an education path, requires too much money. Prioritizes their own citizens. Interesting. Okay, let's move on. These are great. All great. Let's see. Question number 3. As a underrepresented student, have you explored competitive specialties on your own? So with no prompting, have you explored? Let's see what people are saying here. Let's go ahead and look at the responses. All right, so this is really good. I'm seeing some yes, and I'm seeing some somewhat. Not surprised that the somewhat is being taken over. Sometimes I feel like people think it's too early, you need to wait. You don't need to be doing that now. You have so many other things to worry about, right? So yeah, definitely seeing a lot of somewhats here. Let's explore. So maybe let's dive a little deeper into that, right? So as an underrepresented student, have you been encouraged or discouraged by others to explore competitive specialties? So I believe this is a multiple choice one. And then in a second, we're going to kind of explore what some of this messaging is. All right, let's look at these responses. Okay, so I'm seeing I have been both encouraged and discouraged by others to explore. I've been neither encouraged or discouraged. Okay. So definitely seeing some both here. Okay, let's dive a little deeper into that, right? In what ways have you felt encouraged? And what ways have you felt discouraged to explore competitive specialties? So this is one where you're going to be typing, because we are interested to know in what ways has this occurred for you? All right, let's start going through some of these. Okay, you've been encouraged because, yeah, I feel like, hey, you'll make more money, your status might be elevated within the medical community. Interesting, you've been told your specialty is too specific and you might change your mind by medical school. I feel like people love to tell other people they're going to change their minds, right? Encouraged for the need of more Black physicians and the ability to explore, okay? Feel discouraged due to the time span. Yes, people love to say, oh, you're going to be in school forever, right? One of my students yesterday said that someone told her, look, you're going to turn 30 anyways. You might as well be 30 and be a doctor, right? So I thought that was a great, like, sometimes things are about perspective, right? Oh, this is interesting. So encouraged by such an example that I'm able to make it as a first in your family in a competitive specialty. Discouraged by not feeling capable enough. Encourage me and representation inspires you. It's more of an encouragement to do primary care rather than an encouragement or discouragement for specialty. Okay. Feeling discouraged because I haven't seen much of myself in competitive fields. Discouraged because I've told myself I'm not smart enough to even get into medical school. What a powerful statement, right? If you're having trouble thinking like, oh my gosh, like I'm barely going to make it in, how would I become, right, a neurosurgeon, right? If the first part of this seems like a mountain, then the other part is like, you know, going to the moon, right? And we're here to encourage you today. This is not some like unicorn process, right? There is a formula and it's about finding the right people who can help you get there. You are smart enough to get into medical school and you are smart enough to do whatever specialty it is that you want to do. Tell me they are too competitive stuff for someone with your education. Need to pay off debt at a faster rate. Yeah. Discouraged by friends who say, I will waste my 20s in terms of fun and social exploration. You're not missing anything. You're not missing anything, right? In terms of that, these are all really great. Let's take a look at two more questions here. As an underrepresented student, have you hesitated thinking about feeling like you could pursue competitive specialties due to the perceived rigor? So saw a little bit of this on the last slide, so I don't think I'll be too surprised at what we're seeing here. But definitely see an overwhelming yes. Right, yeah, definitely seeing overwhelming yeses here. All right, what do you think are some of the benefits of early competitive specialty exploration? So go ahead and jot down what are some of the benefits of early, and by early, I mean as a pre-med, right? Like as a pre-med, like really diving deep into, I want everything for me on the table. Like what are some of the benefits of that? Let's hit show responses here. More shadowing, finding experience in those specialties, absolutely. More time to do research, yep. The ability to find your academic path catered, yep, and you kind of cater it to your journey. Being more competitive as an applicant for medical school. You can build a passion for the specific field early on, which makes you want to discover new things about it, absolutely. Mentorship opportunities. You know what you want to do ahead of time, yeah. And this is not to say that it's not okay to enter medical school with a completely open mind and do all kinds of exploring, but we can't ignore the fact that if you do know what you want to do, right, it does make it a little bit easier to tailor your med school curriculum, especially in places where you can tailor it to what it is that you want to do. That's kind of some of the hidden curriculum, right, that we see within med school. Be exposed to different opportunities, more knowledge within the field, mentorship, financial and emotional preparation. Yeah, so to everyone's point about needing, it's the long game with some of these other specialties, and you might need a lot more money. So you might be able to definitely financially prepare, emotionally prepare your family, prepare like future spouse, like all that stuff, right? Start to build a resume for application process early. This is awesome. And planning out studies accordingly and staying on top of work. Yep. You learn more about the potential paths when you arrive at medical school. Yeah, you're building off your knowledge, right? It's not the first time you've heard it. So when you are hearing things about it, it's actually sinking in probably a little bit more, right? Yeah. These are excellent. Okay, last question. What are some of the ideas you have for how you can explore competitive specialties early? Now, this is as a pre-med or an MS1, so a first-year medical student, or an MS2, which is a second-year medical student. What ideas do you have for early competitive specialty exploration? Let's take it. We're going to circle back around to some of these. So shadowing, virtual shadowing, mentorship programs. Yep. Research. Yep. Using YouTube and Google. There are so many really cool YouTube videos on like a day in the life, or what do I do? Yeah. How do I spend my days? Summer programs. Yep. Getting in touch with community groups in your university, talk to people in different specialties. Yeah, kind of expand, right? A specialty you would never think of. See if you can kind of sit down with someone and ask them like how it is. Registering with offices that specialize in this knowledge. Yep. Research. Volunteering. Yeah, finding interest groups, reaching out to others. Could email doctors, even though you've never met them and nor know them personally, right? We know that is kind of sometimes difficult to kind of cold email people. But the worst they'll say is, oh, I don't have time to talk to you. I bet you'll hear some no's, but you'll also hear a lot of yeses. Ask professors and upperclassmen about opportunities. Yep, shadowing. Yes, all great. Yeah, all great ideas, and we're going to have some more ideas later. All right, so now we're going to hear from Dr. Okoli, and I'm going to ask her a few questions, and she's going to talk about some of her experience as far as exploring competitive specialties. So, Dr. Okoli, if you can tell us a bit about your background and your current role.
Okay. So I guess good afternoon. I'm Dr. Francesca Okoli, and I'm very happy to be here with you guys today for this conference. I can recall very, very vividly being in your position, a pre-med student with this passion and this drive to go to medical school, and looking for opportunities, for questions, for support. And it was really a very challenging experience. I did my undergraduate at Boston University, which as a URM, I kind of felt like a very, very small fish in a huge ocean. There wasn't a lot of support for URM students to go to medical school. And I think that early on, the pre-health dean made it clear that he didn't think I had what it took to become a physician. And that always stuck with me. So whenever I make it to my next step of this journey, I always want to email him and be like, hey, I made it. Just so you know, I made it. But I went to undergraduate at Boston University, and then I went on to do my public health degree at Columbia University, Mailman School of Public Health. And then I went on to medical school at Nova Southeastern University, College of Osteopathic Medicine. And then I went on to University of Pittsburgh Medical Center for residency in pediatrics. And then the final step on this very, very long journey was I did a fellowship in neonatal perinatal medicine at Columbia University Medical Center in New York City. And for those of you who are unaware, neonatology or neonatal perinatal medicine is a subspecialty of pediatrics that involves the care of sick newborn infants. So we take care of preterm infants, babies who have heart disease, genetic syndromes, dermatologic issues, neurologic issues. It really is an ICU or an intensive care unit for infants. And so it's fantastic work. It can be really sad, but it's really wonderful. And it's interesting, this particular panel in our discussion about discouragement from going into the competitive specialties. I actually spent my entire childhood, adolescence, and early adulthood, thinking that I was going to be a pediatric surgeon. If you look at my journals from all those time periods in my life, it's pediatric surgery, pediatric surgery. When Grey's Anatomy came out, I was like, yes, this is it. This is what I'm going to do. And it was really interesting how things kind of changed for me as I moved along my training path, and I can get more into that. But I think this is a fantastic panel to have this discussion because it's such a prevalent problem for students of color when it comes to picking, our career path.
Thank you so much. A second question is, when did you know that you were interested in your specialty?
Yeah. So as I said, I did have this notion that I was going to be a ped surgeon. And I did a lot of the things that you guys did in terms of researching the background. But I think that there were things that I left out that were really important that helped me realize that it wasn't actually what was going to be best for me. I figured out the timing was going to take, a lot. And for ped surgery, it's 7 years. Most of the surgical specialties that require general surgery are 7 years because you do anywhere from 5 to 7 years of a general surgery program plus 2 years of fellowship. And all of those programs require research. So I was looking at anywhere from 7 to 9 years of doing, of training. And my initial plan was to go right from undergrad to medical school, but there were some bumps along the way. And so I did pursue my MPH in between that time period. And I thought to myself, well, I don't want to add all this time to my life. A lot of things that many of you feel, but I will say that time is valuable and it's important, but what's also important is doing what you're passionate about. I'm lucky that I found something that I love to do, but I do have friends that gave up on what they initially planned on doing and regretted it, very quickly because of the time factor. So, when we're trying to balance out our priorities, time is important, but being passionate, being happy, being fulfilled is to me even more important. And if you're adding on an extra 1 to 3 years, life can still happen. You can still get married, you can still have kids. There are plenty of people in training who got married, who had children, who had 2, 3, 4 children, who went on vacation. It's tough, but I think when you choose this career, you know that you're going to have to make a lot of sacrifices and learn how to be very diligent and meaningful with your time. So if you want something to happen, you can make it happen. So moving into me being a neonatologist, when I decided to pursue pediatrics, which is considered, of course, one of the primary care specialties, I was really pushed towards this avenue of doing primary care, underserved medicine, advocacy, which are things I'm really passionate about. But interestingly enough, when I got to residency, and I was actually in a track for residents who were going to pursue primary care advocacy and leadership, it was called PALS, and it took 2 residents a year. And so we did extra time in the outpatient clinic. And I did enjoy my patients. I enjoyed the pathology. I enjoyed taking care of like social concerns, behavioral concerns. But what I really fell in love with was being in the NICU. It were long days, but I would get up before my alarm. I was excited to be in the unit. I love taking care of the patients. I love the pathology. I mean, beyond helping people when we choose this career, beyond knowing that we can make meaningful impact in people's lives, medicine's really cool. And I feel like that was a rotation that every day I'm like, man, that was really, really cool. When you think about just the pathophysiology of so many interesting diseases and the fact that we are taking infants who were born sometimes 2.5, 3 months early, and they are living, and we're supporting the respiratory function, we're supporting their, their gastrointestinal function, we're supporting their neurologic function, doing things that should have been happening in the womb, outside of the womb. I thought it was just fascinating. And I was actually really nervous because I felt that if I didn't continue the primary care path, I'd be forsaking the commitment that I made to my community, that I'd be forsaking my program. And when they recruited me to do this particular path, I was really torn about it. But I luckily had some great mentors who said, Francesca, do what you love. And you can still find ways to address those concerns that deal with public health, that deal with advocacy within this field. And actually that happened for me. My research is actually in racial disparities in preterm birth and neonatal outcomes, because we know that preterm birth disproportionately impacts infants of color, women of color, by more than 2.5 times out of white women. And so within this field, there's so much work to do when it comes to disparities, when it comes to issues of health equity. And when I made that decision, I did applied to fellowship at the end of my second year of residency, as we typically do when you're applying for a subspecialty in any of the primary care tracks like internal medicine or pediatrics. And I matched at Columbia, which is really competitive program. I was really excited about it, and I loved my 3 years of training. And now I'm here in Maryland working in the NICU, and it's been great. And I think that again, the things that are helpful are kind of knowing who you are and what you want. When I didn't tell you, one of the reasons that I kind of steered away from ped surgery was that my first year of med school, we had a female ped surgeon come and speak to our M1 class about what it was like being a ped surgeon. And I thought that she was so cool. I'm like, this is wonderful. This is fantastic. And then I spoke to her one-on-one, and I asked her about her family life because she had 3 children. She was married. I'm like, I want to be a mom. I want to have kids. This is awesome. You're a ped surgeon. She goes, well, I don't see my children that much. And, for me, my job comes first. I think that's how it has to be. And I was like, oh, don't know if I want that for myself. And I think just from that one conversation with one person, with one personality, I told myself, I don't have what it takes to be a ped surgeon, because to me, family is too important. To me, having a balance is too important. If I can't have that, it's not possible. And, we have a lot of kind of dogmas that we, put out there about what it takes to be a surgeon. You have to be, gruff, you have to be this. But the reality is that there are multiple personalities that exist within those specialties. I think that there is a work ethic that's necessary. You have to be very disciplined. You have to be very studious. You have to be very hardworking. But I have one of my best friends is a neurosurgeon, and he is goofy. He is funny. He is kind. He is patient. He would sleep a lot during our study sessions in med school. So, the personalities are very variable. And, I think it's helpful to think about what kind of attitude it takes to get through those hard specialties. But I think what's even more important is knowing that you don't have to fit into one box to be in that field, which I think we do. There's a lot of that type of characterization when we talk to medical students and pre-med students about specialty careers.
Yeah, thank you so much. So from your experience, were you encouraged to explore competitive specialties like as a pre-med or like really early into your medical school career?
I honestly do not think that I was. And that to me was a pretty big disappointment. I think that at my school, we did not have a very good system for providing mentorship for medical students. We, I think, had good education in terms of the nitty-gritty histology, pathophysiology, anatomy, and whatnot, but we didn't have any type of programming that paired us with other attendings, with other faculty members to help us kind of shape, what our destinies were going to be. And in all honesty, I feel like the surgical, I was part of the surgery club my first 2 years. And again, because I was still exploring that. And, there were no surgical female faculty. There were no surgical faculty of color in that, that were mentoring the students. And so you kind of had an image in your mind of who would be an acceptable applicant for residency. And it always happened to be, quite frankly, white males, with the exception of maybe 1 or 2 males of color in my school. And I think subconsciously that kind of made me feel like I wouldn't have fit in, I wouldn't be good enough. And I think that's what comes into play is like when you don't see someone like you, you often wonder, will I fit in? Will my personality match here? Will I be comfortable here? And it's really unfortunate that I think is the case at a lot of medical schools, is that we kind of typecast what it takes to be a type of specialist. And there's lots of memes and videos joking about the personalities, and they're funny, but I think they do kind of encourage us to think in that small closed box about, who would be a good ped surgeon, who would be a good vascular surgeon, who would be a good rad-onc, who would be, a good, anything. And I think fortunately, even within primary care specialties, when you're thinking about specializing, again, there's not always a lot of encouragement to pursue things like cardiology, gastroenterology, and neonatology. I never met a Black neonatologist until I got to fellowship. And when I was in residency talking about this, I got some encouragement for sure, but I think, again, like when I was looking for mentors, I didn't see people who looked like me. Luckily, there were a lot of females that I think were great, that were helpful, but it's just very interesting that the expectation, I think, especially when you are a student of color applying, or a URM applying to medical school, is that your goal is to go back to your community and work there and take care of patients and, the health, the federally qualified, the FQHCs, which are great. I think it's very important and wonderful that we go back and we better our communities. But if you have an interest in something else, that's also okay. And I think many of us, when we're interviewing, even when I was interviewing, what I sold was like, but I'm going to go back to the community and I'm going to work at a clinic and I'm going to, I'm going to take care of kids and I'll do free healthcare. Like that's what you sell. And I think in many ways we have a passion for doing those things, but we're also almost told that's the best way to make yourself seem like a worthy applicant or worthy candidate. I don't know that police always want to hear that I actually want to be a neurosurgeon and I want to develop strategies for X, Y, and Z. And so I hope that changes because both are important. We need both. But it often feels like the language is such that we have to present ourselves as those who are going to work in a clinic and do primary care to be a student that they want to actually give a spot to in a medical school.
Yeah, thank you so much for that. Very powerful. It's like, yeah, we also need cosmetic plastic surgeons of color, right? Like,
Absolutely.
and sometimes we feel like, oh, I don't want to put that. That's because it could seem shallow. But it's not shallow, right? Like, I remember being fascinated by Tessica Brown's surgeon who got the Gorilla Glue out of her hair, right? Like so needed. And one of the things I think that fascinated us was he understands, right? Like textured hair. He understands how important hair is, like in the Black community, and how awesome that he was able to really take care of her in the way that she needed to be taken care of.
Absolutely.
Okay, so can you talk about some of the benefits? So from your perspective, some of the benefits of early specialty exploration for students of color?
Yeah, I think probably one of the biggest benefits is kind of knowing what you need to do early on to achieve your goals. It's certainly possible that you might change your mind when you get to medical school. I changed my mind when I got to medical school, but the more information you amass, the more you know, the better. And I think it allows you to network better and network with actual purpose and intentionality. That's very important. We put a lot of emphasis on things like shadowing. I think shadowing is great. It's nice, but I also think that shadowing, take with a grain of salt, because it's very different kind of standing in a room, watching something happen versus being at the bedside and providing the patient care. And so you may shadow and feel like this isn't for me. I don't know that I like it, but there are people that actually were in medical school in their third year and they weren't even expecting to like a particular rotation. And then they ended up loving it. And that's what they ended up pursuing. So I think the early on that you explore, I think the more information you gather, the more people that you meet, the more connections that you make. And I think it's nice to talk to different types of people. It's great to have like one family friend who's a surgeon you can talk to, but see if they can connect with other colleagues, because again, there's so many different personalities, there's so many different perspectives. One person may have found that for them, it was about the money, actually. One person may have said it was about the science, it was about the love for the bones. I love that part. And then you get to put a bigger picture together as to like what would work for me, what wouldn't work for me. And I think then you also feel when you get to medical school that you can amass the kind of grades and scores that are going to be important. I hate that we place so much emphasis on the scores and the grades, but unfortunately, for the time being, that's our system. Right now, we're getting ready to put together interview invitations for fellowship. And the things that we're looking at really are the scores and the grades. And these are for people who are in residency. So it's like, why does our medical school and USMLE scores even matter at this point? Like, how do they do in residency? But those things carry with you, unfortunately, even when you're applying for training programs. So you're not going to be in school, but you're going to be in a training program. And so the early on, just better preparation, in all honesty, is what really helps you. And if you can kind of make those connections before you even get to medical school, it goes a long way in terms of when you're applying for residency and you have those questions like, hey, what kind of essay should I be writing? Like I helped several actually medical students this year with reviewing their applications for residency, for surgical fields, for primary care. And these are people that I met while they were pre-med. So I think that kind of networking is just super, super important. And like there are people that, I had a friend who was an orthopedic surgeon. And so I said, can you also help me with this mock interview for her? And together we mock interviewed her, which again is a thing that not everyone can do to prepare for residency. So when you can do those kind of things before you even start, you're basically amassing like a resource and a toolkit that helps you really be in a position to match where you want to match.
Yeah, thank you so much. And that you kind of also took care of our last question. And so we're going to move on because I definitely want, we have some questions I see building up in the chat, and I want to make sure that students are able to ask you some additional questions. So here's just a few. You guys came up with some really great ideas, but here's just a few ideas for early competitive medical specialty exploration, especially for pre-med. So you guys definitely came up with, like, I know Dr. Ryan Gray has a great like e-shadowing program, YouTube, social media, going to workshops, shadowing clinicals, seek out mentors, right? We cannot stress that enough. You can conduct informational interviews and then, definitely attend workshops and events that your institution is putting on. Here's some ideas for early exploration as a first-year medical student or a second-year medical student. Well, the first one is, as a pre-med, right? As a pre-med, when you're at second look, you should be asking your medical school, how do they expose students early to competitive specialties? So like if you're a first-gen student, how can I explore otolaryngology or orthopedic surgeons or ophthalmology? Then when you get into medical school, you need to inform your medical school career advisor, so hopefully your school has those, early on, like, hey, I am interested in exploring some of these competitive specialties. Make it known. I had students in my office that would whisper, like, I'm interested in ortho. I'm like, why are we whispering? Just say it, okay? I'm gonna help you find an ortho mentor. Say it loud, proud, tell people early that this is what you want to do and advocate for yourself along the way. Mentors, mentors, mentors. Connect with programs as soon as you decide so you can start showing early commitment, okay? Last words of advice before we go to Q&A. Do not count yourself out. You got this. Do not decide based on test or board scores, like Dr. Okoli said, and do not be discouraged by the low numbers that sometimes you're seeing within those medical specialties. They want you, right? They want you to apply. They want it on your radar. A lot of them are looking to increase their numbers in these areas. But it's kind of like the lottery, right? You gotta play in order to win, right? And so throw your name in the hat. Don't count yourself out. You got this. That's what we have for you. And I will go ahead and stop sharing and we'll see what questions you guys have. Thank you.
Thank you. That was a wonderful presentation. Gallery, there you go. All right, let's start with some of these questions. Ooh, there's a lot more coming in as we talk, so that's super exciting. Okay, I know this might be a very common question. This keeps moving. However, I would like to know if virtual shadowing is acceptable for medical school applications.
As far as I'm concerned, from our experience from the medical students that we've interviewed, it is. Especially as we've now entered this era of the COVID pandemic, it's become one of the more, unfortunately, like mainstream ways of students getting exposure to some of the medical specialties because of minimizing increased like traffic into the hospitals. So yes, it is something that I've seen on applications now that we are interviewing medical student applicants for spots here if they've e-shadowed. What about you, Dr. Nguyen?
Yeah, I'll echo that and say, when in doubt, you can email the admissions office and also ask them, right? I know we were talking with like Rush Medical College a couple weeks ago, and they were still wanting to see just a little tiny bit that you've smelled medicine, right? Like you've smelled some stuff, you've been around some patients. So when in doubt, it's always the safest route just to email them. I promise you they'll tell you like, hey, yes, it's completely fine, or we do want to see something either before the pandemic started or that you've been able to do a little something with the pandemic.
Perfect. Do you feel pressured going into a specific specialty, being an underrepresented minority, that would specifically help minority health more?
That's a great question. I think that question came in as I was answering it. So I saw it pop up, but I think, yes, there was a lot of pressure to pursue a primary care pathway. And there's a lot of guilt at times when you don't necessarily go into that pathway. And I think that the way that to compensate or to reconcile those two things is that within every field, there are going to be disparities that need to be addressed. And so if you really have a passion for making sure that you're impacting your community, but you don't necessarily want to be a family medicine doctor, you don't want to necessarily do general internal medicine or general pediatrics, then to kind of balance those two by trying to do research or in your own personal work ethic or the way in which that you function in your hospital, to address issues that are based in health inequity. But I definitely think that there's extra pressure. And I think, I understand where it comes from. I think we know that data tells us that when you have folks that look like you working for you within your hospitals, the outcomes are better. And so I think as we're trying to revitalize this very broken healthcare system, it's a strategy that is important to use. But I think we also need to make sure that students are pursuing their passions and their dreams and not just being forced into something that to be part of a machine, to fix a problem that they had nothing to do with to begin with. So.
All right. Next question. Can you speak to pursuing specialties as a DO student? Would you say it's more challenging than if you came from an MD background?
That's a great question. And I actually got a lot of warning that it was going to be challenging for me when I went on to do osteopathic medical school. And I guess I'll give my age. I went to medical school in 2010. And I think we've come a long way in the last decade in terms of competitiveness when it comes to doing allopathic versus osteopathic residencies. I actually only applied to allopathic residencies, and I applied only to top 10 children's hospitals. I matched at my top, my number one choice. I think if you're going to, things have changed now. They've been doing a lot of work to make a single system for residencies. I actually haven't checked back to see where we are with that. But when I was leaving medical school, that was the big platform from our organizing body and the AAMC. I think ultimately the same thing applies, being good about mentoring, getting good mentors, having, unfortunately, good board scores. Again, don't let that discourage you. If the board scores don't match or don't seem to be close to the average of what you're seeing for that specialty, that means you're gonna have to work harder in other areas, network a little bit better, and find people to kind of advocate for you. But I ultimately found that because I had a good resume, I did a lot of great community service, I did public health school prior, I think I'm a hard worker, I had good grades, that made things easier for me. So do not think that because you may have a DO or an MD that you cannot pursue competitive specialties. It might require sometimes for places that are a little bit more old school, a little bit more pushing, but it's certainly possible. And you just got to find the right people to help you out with that.
All right. What is the best advice to find mentors early on without any connections?
I would say conferences like this are wonderful places to meet mentors. And I think even beyond making a mentor, the question and the thing that I think I filled out was keeping mentors. You're going to meet a lot of people who might give you a business card, who say, reach out to me. And I would just file it in my little pocket or put it in my little portfolio, and I would never reach out to them again. I was horrible at mentorship or making networking connections and solidifying mentors when I was a pre-med student and even a med student. And I think that is a job that is really worth a skill really worth honing. So when you go to conferences, when you go to even your own doctor's office, I think starting there, asking your own physicians, I'm really interested in medicine. Would you mind, if I know you have a very busy schedule, can we chat sometime? But being purposeful and being good with communication. I tell my mentees that what they should do is when they get a business card from someone that they meet at conferences or networking opportunities or panels, that to draft an email that they send every 3 to 6 months of updates. Hey, this is so-and-so checking in with you. We met at this conference, we met at this meeting. I wanted to let you know that I'm still interested in medicine. In the last 3 months, I've been doing this, this, and this. I really enjoyed meeting you. I just want to let you know what I'm doing, and hopefully we can continue communicating on a regular basis. And that way you stay on their radar, that way you stay in their inbox, and just make it a habit of sending that kind of email every 3 to 6 months so that you're not losing out on an opportunity to have someone mentor you. And someone mentioned the cold calling or like the cold emailing. That might be a little bit challenging. And I'll say that sometimes people won't even respond at all. But if you can go to more so like a university, like Hopkins, University of Maryland, whatever major universities are at your institution, if you reach out to people in those medical schools, I think you'd be a little bit more successful in finding people who are interested in mentorship. And I also think organizations like NPHC or NPHC, SNMA, Student National Medical Association, AMC, those are great places to find physicians who are more than willing and would love to mentor, really driven, compassionate students like you guys.
Perfect. Thank you so much. Unfortunately, that was all the time we had. So thank you again, Dr. Oakley, Dr. Nguyen, for coming and talking to our students about this. I also saw that there were some questions answered through text, through the chat as we were doing that Q&A. So feel free, students, to read those. We'll leave those up for you guys. So we will be moving on to our lunch and also tabling sessions. So stay tuned for some more information about that. Thank you. All right, everybody, welcome back from lunch. Our next session is a special event with sponsors that have helped promote our conference from all over the country. We have 5 tabling sessions for you, one from Simply Neuroscience, Alpha Epsilon Delta, American Medical Women's Association, the American Medical Student Association, and the Health Profession Student Association as well, which also publishes Student Doctor Network. And all 5 of these sessions are very unique, and they will be discussing events and opportunities within their organization from all over the country. I highly recommend that you choose one of them and stay for the entire session to learn what events and opportunities you could be involved with after the conference ends. And so I will send a slideshow into the chat, and you can go onto one of those slides with these logos and click on the link to be taken to the tabling sessions. An MPHC team member will also be present within these sessions to help you get back to the webinar once the tabling session is over. So go ahead and hang tight while I add these links, and let me know in the chat if you have any questions.